కంప్లీట్ కాపీస్ తీసుకున్నావా?
మనతోనే పంపించారులే.
సారీ కామేష్, లవ్ అవుతుందనుకోలేదు.
నీ తొక్కలో సారీ ఎవరికి కావాలి?
to the sessions. May I call upon Dr. to please share the session. Dr. Ramesh Bigla sir to Akash sir.
Yeah, good morning. Good morning. I'll request all of you to the front rather than sitting behind. All of you can come to the Sellar seats vacant. Please come up to the front. All delegates come to the front. Faculty can sit behind, no problem. All delegates, please come to the front seat. All of you come to the front seat. Come to the front. Good morning. Today we have a busy day. We have morning lectures on how to do and how to do different surgical approaches, starting with radiology anatomy, and then followed by we'll have demonstration in cadaver, and both in the morning and evening session, and people can have hands-on experience also. Followed by again we have a list of lectures. The first lecture is by Dr. Subhendu from Adenoma Institute of Neuroscience. He's a neuroradiologist, and he will be speaking on sphenoidale applied anatomy and what neurosurgeons should know. Thank you, sir. Thanks to the organizing team for the opportunity. So, this presentation is mostly pictures, and it contains things that over the years I have found confusing and difficult to understand. So, I'll say a few things which you can, which may be important for you to build upon it. So, to start with, a brief, orientation. So central, you have the nasal cavity, on either side the maxillary sinuses. Above the nasal cavity is your ethmoid air cells and the cribriform plate, on either side of which are the orbits. So in the nasal cavity, what is most important for you is the middle turbinate. But before that, these are two things that I'll keep repeating. In paranasal sinuses, variations are the rule. They may be different on each side also of the same patient. Variations are to be expected and should be explored before, means on imaging, before undertaking any sort of procedure that involves access or passage through the sinuses. So to start with, this is the ethmoid bone. So this is from the front, this is an oblique view. This is the nasal septum. This is the middle turbinate. What you can see, this is the uncinate process. Again, it is difficult to imagine the relationship between the middle turbinate and the uncinate process. That's why this. And this union here is the axilla of the middle turbinate, which keeps coming in endoscopic literature. So where the middle turbinate meets the lateral wall is the axilla of the middle turbinate. Now the anatomy of middle turbinate means from the days of MBBS, it's difficult to understand. I'll come back to this in a while. So this is the middle turbinate. It has three parts. The three parts are in three different planes. So the first part, this is anterior, this is posterior. So the first part is in the sagittal plane. The second part is in the coronal plane. The second part is your basal lamellae that divides the anterior and posterior ethmoidal cells. And the third part is horizontal. So it is really a three-dimensional structure. This is a very simplified version of it, and this is the actual thing. So these are the attachments of the middle turbinate. It is important to understand the anatomy of middle turbinate because it is a major landmark in the nasal cavity for many structures. The second thing to keep in mind is the development of the sinuses. Why development of the sinuses? Because the sinuses are air within the bone. So they form, this is the ethmoidal air cells. So this is what is seen in the newborn. So in short, they develop from, or they pneumatize from inferior to superior and from anterior to posterior. So if we, as we will see the variations. So in a patient or in a subject, the pneumatization can be more or less. So all the structures in relation to whatever sinuses that we see have the potential to be within the sinus. Any structure which we learn to be outside the sinus or related closely to the sinus is likely to be potentially within the sinus because of these variations in pneumatization. We'll see pictures of these again. So to say, ethmoid sinus, the air is filled from inferior to posterior and inferior to superior and anterior to posterior and from medial to lateral. So the posterior extent can stop at a particular place. So that is the minimum or the maximum pneumatization of the sinuses. So anterior to posterior, medial to lateral. Ethmoid is inferior to superior and anterior to posterior. So this is again the middle turbinate that I have already told. So this is again to show the axilla of the middle turbinate. So this is your nasal septum, middle turbinate, where it meets the lateral wall of the nasal cavity is the axilla of the middle turbinate. So we'll come to this table when we are discussing anterior ethmoidal artery. So the ethmoid air cells, if we see on imaging, it looks like a very chaotic space, but there is some order to that chaos. So in order to imagine, we can imagine the sella. The sella is a saddle-shaped structure, like it is concave superiorly and maybe posteriorly. The same, we can extend the same imagination anteriorly. So these are the lamellae of the ethmoid air cells. So you have first and second lamellae, third lamellae. The third lamella is important. The third lamella of the ethmoid. Lamellae are the partitions of the ethmoid. So the third lamella of the ethmoid is the basal lamella or the second part of the middle turbinate that we just discussed. This divides the anterior and the posterior ethmoidal air cells. So the fourth lamella is the lamella of superior turbinate or the attachment of superior turbinate to the lateral nasal cavity or lamina papyracea, and the sphenoid sinus, anterior wall of sphenoid sinus is the fifth lamella. So medial to the ethmoid, all these lamellae are attached medially to the lamina papyracea. So the attachments are important, and superiorly they will be touching, as you can see on the CT, they will be touching the cribriform plate. So these attachments are important because while dissection of these lamellae, the attachments can get damaged. So medially there can be damage to the lamina papyracea and superiorly the cribriform plate. So this is orbit, and this is from the superior. The second picture is when we are seeing the cubiform plate in the superior. This picture shows the ophthalmic artery and the anterior artery that arrives at the ophthalmic artery and goes immediately is the anterior ethmoidal artery, posterior ethmoidal artery. So both ethmoidal arteries have their origin from the ophthalmic artery within the orbit, and they form an anastomosis just lateral to the cubiform plate. So the course, that is from the origin to the exit from the near the cubiform plate at the anterior skull base, this part passes through the ethmoid sinus. Now, like I said, any structure that is related closely to the sinus can potentially lie within the sinus. So this is again to show the anatomy more clearly for us to be able to imagine it. So from the medial, that is from the orbit, they travel through the ethmoid or on the top of ethmoid to reach the cubiform plate. Now the other picture shows the green colored anterior ethmoidal layer cells and the posterior ethmoidal layer cells. Like I said, the anterior and posterior ethmoidal layer cells are separated by the basal lamella. One more pointer can I have? So that is why the basal lamella is so important. The position of anterior ethmoidal air cells is most commonly between the second and the third lamellae. That means it is for most patients anterior to the third lamellae, that is the basal lamellae, or within the basal lamellae. So these are a list of studies that have investigated. In one study among all this, only in one study it was found that it was not predominantly anterior to the basal lamellae, but in all other studies it was like anterior to the third lamellae, that is the basal lamella. This is the in relation to the skull base. The exact incidences of all this is variable. Many people say that the third type, that is when it lies within the ethmoid air cells bound to the skull base by a mesentery, is the most common, but other varieties are also common. So, but some say, so the blue thing is the skull base or the bone, the red thing is the artery. So it can be within the skull base, just inferior to the skull base, or hanging in the ethmoid sinus by a bony mesentery. So this is again, we come back to the sinus, the middle terminate axilla. On the table on the right side, in the third table, we can see the distribution or the location of the anterior ethmoidal artery in terms of distance from the axilla of the middle terminate. So now a very important thing is injury to the anterior ethmoidal air cells. So anterior ethmoidal artery can be injured if it is within the sinus, or it is the riskier position is within the sinus. So anything that causes increased pneumatization or more air in the region of the ethmoidal air cells can lead to increased incidence of injury to the anterior ethmoidal artery. So the presence of a supraorbital ethmoidal air cells, that means ethmoidal air cells going into the top of the or the roof of the orbit. If a supraorbital ethmoidal air cell is there, the anterior ethmoidal artery is more likely to be within the sinus. Same thing if the lateral lamella, that is the part of the ethmoid bone lateral to the cubiform plate and medial to the fovea ethmoidalis. If that is either wider or longer, that means the olfactory fossa is deeper or the anteroposterior length of the lateral lamella is longer, these anatomies are more associated with a deeper place or intrasinus course of anterior ethmoidal artery. Anterior ethmoidal artery foramen is very easily seen on paranasal sinuses CT. For residents, you have a lot of trauma cases, especially for facial trauma. In all those scans, you can explore the anatomy of the anterior ethmoidal artery. then you'll get used to identifying it before your surgery. So like I said, and ethmoidal air cells pneumatizes anterior to posterior. So we have seen supraorbital air cell. This is the onodi cell that is just above the sphenoid sinuses. So this is very closely related to the optic canal on either side. So this is usually not filled with air. So there is a potential to damage the optic nerve if this cell is entered. On the right side, you can see on the right medial wall of the right orbit, we have a deficiency in the lamina papyracea with fat extending into the ethmoidal air cells. So DLP stands for dehiscent lamina papyracea. So here there is potential of lamina papyracea injury or injury to orbital structures because orbit is essentially encroaching onto the ethmoidal air cells. So next we go to the sphenoid sinus. This is a diagram you are more familiar with. So the center is the midline, superior is anterior, inferior is posterior. So this is a schematic for it. So this is a very, on the left, whatever diagram is there is a very nice picture because everything is so clearly defined. But in practice, it may not be so. So here two important things we have to see, that is the MOCR and LOCR, that is medial opticocarotid recess and lateral opticocarotid recess. As very evident in the diagram, it is useful to identify the relationship between the carotid or the internal carotid artery and the optic prominence, that is the optic nerve. So this is on the CT picture, that is the whatever is pointed to it is the medial opticocarotid recess. So again, for sphenoid sinus, if it is typically pneumatized, the internal carotid artery and the optic nerve should be outside the median nerve, and the foramen rotundum all should be outside, and their structure should be outside the sinus. If they are more pneumatized than expected, we would see this is pneumatization of the anterior clinoid process. So this puts the optic nerve at risk for injury. Same thing, if the pneumatization extends to the sphenoid wing, the foramen rotundum, median nerve, and the second segment of the mandibular, fifth cranial nerve are susceptible to injury. The extreme forms of those are the dehiscence of the internal carotid artery. So internal carotid artery lies closely to sphenoid sinus. Any structure that lies close to a sinus is potentially possible for that structure to be within the sinus. So this is the internal carotid artery projecting into, and there is a deficiency of the bone that lines the internal carotid artery. So this is dehiscence of the internal carotid artery, and it is projecting into the sphenoid sinus. Same thing for the optic canal. This is right, left, normal. This is onodi cell. And we can see that the medial wall of this optic canal is deficient here, and it is projecting into the air cells here. Same thing with the median nerve and the foramen rotundum. One more important thing to remember for sphenoid sinus is this intersinus septa. These are additional septa within the sinuses, and they may attach with the internal carotid canal or the optic canal, and handling or dissecting this can lead to potential damage to the bony wall and hence the structure underlying, that is the ICA. I think that's it. Thank you.
As we're running short of time, we'll have questions later after every 3 presentations. The next presentation is by Dr. Krishna Prabhu from Vellore. He's a professor of neurosurgery, and he'll be speaking on anatomy of the pituitary, carotid, and cavernous sinus.
I want to thank Ramesh for inviting me to the workshop. My first visit to Kamineni. Thank you very much. I will briefly talk about the anatomy of so I'll briefly talk about the anatomy of pituitary, IC, and cavernous sinus. Now, it's a very vast topic, and I'm not sure how 10 minutes can present, but I'll try and give a nutshell of the view of all this. If I exceed time, please forgive me. So the Sellar, if you don't look from the cranial view, the anterior process, ACP, that's the anterior process, it projects posteriorly from the lesser wing of the sphenoid, which you're all familiar with. And it connects with the sphenoid body anteriorly via the anterior root of the lesser wing of skin and posteriorly through the optic structure. You're all familiar with this part from the cranial end of it. Now, if you go little more laterally, you have the MCP, middle canal process, which is not so present in most of them. Some patients have, some people don't have. It projects laterally from the anterior third of the lateral wall of the Sellar in the middle, and you are the middle aspect of the carotid sulcus. So that is very important. That middle MCP is very important because that's what you're going to see from the other end. The posterior kind of the PCP, it projects laterally at the superior angle of the dorsal sulcus. So these three you have to know: ACP, MCP, and PCP. So the next terminology that you need to aware of is the LPC, what I call the lateral tubercular crest. This is basically an eminence at the lateralmost edge of the tuberculum sellae and the medial aspect of the carotid sulcus. Now, the corresponding to this, I will present from the endoscopy. So remember this term. So the LPC, which is an eminence, the lateralmost part of the tuberculum sellae and the medial aspect of the carotid sulcus. So next, you have the tubercular optics bridge. I'm marking with the asterisks. So that is basically it's a concave bony segment that connects the LPC to the medial aspect of the optic structure. And of course, the chiasmatic sulcus, which is a shallow trough in the upper surface of the sphenoid bone anterior to the tuberculum sellae. So now, whatever you saw from the cranial end, you should be able to correspondingly be able to correlate from the endoscopic viewpoint. So if you do a 0-degree view, that is A before and after completion of the bilateral anterior and posterior ethmoidectomies and sphenoidectomies. So you remove the ethmoid, you remove and sphenoid. This is what the view you will get. The center, you have a Sellar, and rostral is the tuberculum sellae and planum sphenoidal, which you're going to see chiasmatic sulcus. Tuberculum, chiasmatic, and planum you're going to see. And caudal, you're going to clival regions and clivus you're going to see. So you're all familiar with this midline anatomical structure. Now, if you have a well pneumatized sphenoid sinus, the Sellar tertia is located centrally above the clival recess, and which is limited by the paraclival. So you have the paraclival and the paracavernous. So both you have the paraclival cavity. So the Sellar is bounded laterally by the carotid prominence. So you have the Sellar, you have the carotid prominence. So which is basically the anteriormost projection of the ICA. Superior to Sellar is the tuberculum, and like I mentioned earlier, chiasmatic and sphenoid, which are all familiar. Now, if you go laterally, the pneumatization lateral is something, you may see the LOCR and the Ethmoid, which I'll come to later. So I mentioned about the lateral tubercular crest from cranial view. Now, if you look from the endoscopic view, from the looking at what is called lateral tubercular recess, it's an osseous depression at the lateralmost edge of the tuberculum cell. So you have your LPC, which is in cranial view, LPR here, and this LPR is connected to the LOCR via a dorsal arch, the dorsal osseous arch, which covers the carotid. And you have your LOCR here. So basically, the LOCR is a triangular osseous depression that represents the ventral surface of the optic strut when viewed from sphenoid sinus. So basically, if you identify the LOCR, you're looking at the optic strut from inside. Remember that. And bordering the LOCR above is the superior the optic canal. You have a superior optic fissure inferiorly, you only have the carotid here. Most of the time, bone is covered, but sometimes the bone may be division are very thin. So when I've been endoscopic surgery, you need to be very cautious and be aware the fact that bone may be deficient here. Now, LOCR, actually, the MOCR is a tear drop shaped osseous formation formed by the middle junction of the paraclinoid canal and the optic canal. So LOCR and your MOCR here. Because of this location of confluence of optic canal, carotid, and the anterior canal base, this MOCR is the landmark for endoscopic approach. So any endoscopic approach, and MOCR is the most important landmark, in which what's called the keyhole. Because of the confluence of all these things. This is what you see in a realistic view. So the MOCR is the most important point you can identify. The keyhole. So if you drill the Sellar, you identify LOCR, MOCR, you drill above, you remove the tuberculum. Depending on the tuberculum, you will enter the cranial cavity. This is what you're going to see, chiasm, optic nerve, the pituitary stalk, and your vessels are going to be seen. And if you drill further, you're going to see the apical fossa. So you're going to see the basic frontal region, acorn complex vessels. Now, once you remove the bones, and this is what you're going to see, this is the segments of the ICA. So you have a paraclavicle. So the cavernous, the parasellar ICA, what we call, basically two components. The parasellar component for a cavernous segment and a paraclinal segment. So this cavernous segment has got divided into a short vertical, a posterior genu, horizontal, anterior genu. Remember that. You have a short vertical, posterior genu, horizontal, and a vertical segment. Anterior genu. So, if you look at the cavernous sinus, which is the patch intravenous venous structure, it lies on the either side of the pituitary program, the venous channel. It basically narrowed the anteriormost aspect and near the superior orbital fissure, and wide posteriorly closer to the lateral to the dorsal cellule. There it opens into the venous conference formed by the basilar and sphenoidal pituitary sinuses. You have basically there are 5 walls. You have a anterior medial wall, you have a roof, and you have a posterior and lateral wall. Basically, this floor is not well formed. Basically, but remember that. So, once you have drilled the bone and you see the thing, you're going to see the structure dura. Now, dura got 2 layers. Everybody knows that there's outer periaster in the meningeal layer, and this is what's covering it. So once you drill, you take away the outer periostal layer. If you go here, the outer periostal layer is going to extend from over here and go across the cavernous sinus. This forms probably a wall of the anterior cavernous sinus. So once you take the outer periostal, you're going to see the inner meningeal layer. This inner meningeal layer, it does not continue. It just turns inside and goes and separates. Remember, it forms the medial wall of the cavernous sinus. So basically, the anterior wall and the medial wall of cavernous sinus are formed by a single layer of dura. That is the crust ligament. So you have over the Sellar, you have your anterior and outer periosteal and inner meningeal. But as it goes laterally over the cavernous sinus, anterior cavernous sinus wall, only the periosteal layer, inner meningeal layer forms the medial wall. A single layer. That you should be aware when you're doing surgery. This is just to show that actually done this case yesterday actually. A tumor, large invasive tumor was there present in the Sellar sphenoid and in the cavernous sinus. So we removed the Sellar part, and this is the medial wall, and this is basically showing the carotid of the ICG. Yeah. So once you see the imaging through the cavernous sinus, typically the medial cavernous sinus is attached to medial wall is attached to the keratoclinical ligament. Now, this ligament actually arises from the middle clinoid, and it consists of multiple small thin fibrous bands that suspend the medial wall of the cavernous sinus, and they finally converge to form a strong bond, and which goes around the anterior genu of the carotid, to eventually to merge with the intercranial ligament. So this is how initially they are thin fibrous bands. Later they form a stronger bond, go towards it, and they connect with the intercranial ligament. between the parotid and the middle segment, there are thin filamentous additions. You can see it in cadaveric detection. You can see it can actually notice the thin filamentous addition between gland and the middle. So the cavernous sinuses itself, because based on the course of the carotid artery, is divided into 4 compartments: superior, inferior, posterior, and lateral compartments. So classically, the cavernous sinus has been accessed through transcranial, through the roof, through the clinoidal and oculomotor triangle, and laterally through supratrochlear, intratrochlear, intermediate triangles. But for intracavernous sinus through endoscopic surgery, these divisions is important because that will help us to decide which compartment the lesion is lying and how to approach that. So if you see the lateral view, the superior compartment is located above the horizontal segment. Basically, it contains the third nerve and the fourth nerve. So that is the superior compartment. The posterior compartment is here, which basically located posterior to the short vertical segment and behind this. So superior and posterior segment actually it turns the junction of this happens around the posterior genu region. The important structure in the posterior compartment is basically your endoscopic trunk, which I'll come to later. So the inferior compartment basically lies beneath the horizontal, below the horizontal segment. I said above superior, behind short vertical posterior, below horizontal, you have your inferior compartment segment. Usually the sympathetic plexus lies here. The lateral compartment, which is actually the most difficult to access, if you're going from your endoscopic point of view, going medial to lateral, is the lateral compartment. I will go to that one. So the 2 arteries that we need to say, one is the meningocarpical trunk, which I mentioned, arising from the posterior compartment. Basically, these 3 branches: the tentorial artery, the inferior epiphyseal artery, and the dorsal meningeal artery. And your other branch is the infralateral trunk. It's also known as the artery of inferior cavernous sinus. So because of short of time, I will close my talk. Thank you very much.
Thank you, Dr. Prabhu. It was very clear in the discussion of the anatomy and explanation. If anybody has any questions on the 2 anatomy lectures. There are no questions. Dr. Ramesh wants to skip his lecture in view of shortage of time. So I'll request Dr. Vamsi Krishna, Additional Professor of Neurosurgery of Nizam's Hospital, to present on surgical nuances of endoscopic endonasal pituitary surgery. While this PowerPoint opens up. Thank you, Dr. Manas, Dr. Reddy, and Dr. Ramesh for organizing this interim course of the MASI. My topic is on the surgical nuances of functional adenomas. I think someone is going to cover the basic approaches. The lecture was before this one. So yeah, so the thing is, like,
the problem with the functional adenomas is basically the achieving the remission rates. A lot of times we remove it grossly, but still the hormone levels doesn't come down. So that poses the biggest problem. And we do the post-operative scans, and we realize that the tumor has been removed. I mean, it's very difficult for the radiologist to identify it, but never the hormone levels have never come down. So that's where the nuances has come down. For 20, 30 years, like, I mean, there's not much improvement. There's not much change in the results, but in the last 10 years, like the endoscope coming into the pituitary and transnasal endoscope, oh my God, it's not opening up, right? The transnasal endoscopy coming in and giving better view, and the anatomical dissections which have shown has given us much sneak peeks into what is the anatomy around the cavernous sinus, around the pituitary, and how we can completely achieve that these all the cells and small portions of those tumors which extend into the so the remission rates have been 50 to 70% throughout, and the surgical nuances that happened within the past 5 to 10 years has basically ensured that we achieve better biochemical remission rates, which is very much important for the patients to be completely symptom-free. And if you look at it, most of these these things have come from the realization that these tumors invade the cavernous sinus medial wall while the tumor remains in the pituitary. The medial wall that's the meningeal layer and of the dura, which is there wrapping around the cavernous sinus, that gets invaded by the tumor. So removal of that one and how to remove that, these are the things, I mean, which have developed over the past 5 to 6 years or 10 years time period. And most of it has come from understanding the anatomical layers, dural layers around the pituitary gland. And if you see, like, all the functional adenomas, like including growth hormone is the one, acromegaly, like growth hormone secreting tumors are the one which invade the highest of the medial cavernous sinus wall. And they are the worst in terms of having the remission rates. I mean, the remission rates were only 50%, 50 to 60% maximum, even in the best of the hands, like maybe 6, 7 years back. So that's where the medial cavernous sinus resection walls have become much more mandatory in cases of the functional pituitary adenomas. And if you look at, this is a Stanford series where the medial cavernous sinus wall was removed in toto and sent for analysis, and except only 20% were negative. And that's where they started, once they started doing this, they achieved the remission rates. And initially, Oldfield and John Jr., these are the people, I mean, who started, Oldfield was the one who started of extracapsular resection of tumors, and partly the medial cavernous sinus wall removals. And Japanese as well have come to into the same thing. And they achieved much higher remission rates, close to the 60% was the best remission rates achieved by the Japanese. But the exact how to be removed and what is actually finally causing remissions were not explicitly described in terms of anatomy and technique. So this is the basic anatomy already the previous speaker has dealt with. There are two layers, the meningeal layer which wraps around the pituitary, and there are suspensory ligaments from the meningeal layer around the pituitary which goes and hangs it around the pituitary, and as well as the superior set of ligaments, the caroticoclinoidal ligaments they are called. And these are inferior parasellar ligaments. And there is the external dural layer, the periosteal layer that we see. And these are the different ligaments. It has already been dealt with. So this is the cartoon depiction of how these ligaments look like. Because when we want to remove the medial wall of the carotid, all these ligaments are the one which are the one which needs to be cut to remove the medial wall. And typically, how this progresses is like the anterior cavernous sinus wall has to be opened. So the anterior cavernous sinus wall opening has to be done. The carotid needs to be visualized, and the cavernous sinus is, it's a venous lake. So we need to inject flow seals and get the bleeding control. And from here, we start cutting it and removing it. So this all comes after opening the dura and removing the tumor completely along with the capsule. So that becomes the last portion. So it entails that we drill over the sella, which we do standardly, and as well as the carotids, and as well as onto the tuberculum, and below a part of the posterior clinoid ligaments. So the schema how this is removed. That's the medial cavernous sinus wall where the tumor cells are attached, and the anterior cavernous sinus wall is open, carotid is visualized. From here, the entire dissection proceeds to see these things. And the carotidoclinoid ligaments, the first thing that starts is cutting the inferior parasellar ligament and coagulating the inferior hypophyseal artery, then cutting up the inferior set of ligaments and developing it up, and then cutting the carotidoclinoidal ligaments and removing the complete wall. And this wall is sent for biopsy as well. So that's the same thing depiction in the anatomy around this. So this the cases of Cushing's adenoma, like we did how these things are done. After the nasal part is done, like here already the entire sphenoid sinus has been wide open, and the Sellar and the drilling over the carotids have been done. And closely is something that you have to be very generous in using the controlling the venous bleed. So after the entire drilling is done over the carotids, MOCRs, and tuberculum sella and below, see the dura is open, and quite often once the wide exposure of the sella is done, it's very easy for most of the functional adenomas. We don't find the problems that we faced with under the microscopy to identify the adenomas. So we can clearly see the adenomas. Even in one where we are finding it difficult on the scans, they are very easily identified intraoperatively. So once this is done, like the anterior cavernous sinus wall opening is done, then here the flow-seal is injected. And before that, missed the step of coagulating the inferior hypophyseal vessel. That's very important. Otherwise it bleeds. And from here, we'll start developing this with blunt dissection and with scissors. And this is done on both sides because this tumor is extended to both sides of both the walls. So both sides cavernous, medial cavernous sinus walls are removed. And if there's sometimes there is some small completely invades and enters part of few of the cells go around the carotid. Even all the compartments around the carotid as well are explored to make sure that entire of these things are entire of the tumor cells are removed. So this is the one with acromegaly, and acromegaly poses even a bigger challenge because it is much more okay. So this is how the medial cavernous, the tumor is completely adherent to the medial cavernous sinus wall. That is something which we can identify it on the scans in a lot of cases, but in some time, even it is not identifiable on radiology, it is still recommended that we remove it. I mean, the moment tumor is there, we have identified in many cases where you don't see it. The tumor seems to be sitting in the central, but coming close to the medial cavernous sinus wall. And that has been removed. So that resulted in the remission. So we have done, this is our, that is where the remission rates have gone high. There are cases still, which fail. And once the technique has improved, we are now able to send the entire medial cavernous sinus wall for biopsies. And in the last 4 cases that we have sent complete medial cavernous sinus wall, in all the cases the tumor has been identified. Out of them, 3 are acromegaly and 1 is Cushing's. So most of these functional adenomas, they invade the medial cavernous sinus wall, and it's very important that we remove this thing, and we gradually develop that technique to do it. Thank you.
Thank you, Ramchi. I call upon the next speaker, that's about to share his views on universal approach to pituitary adenoma. I worked in this hospital for 11 years, 2005 to 2016. It's always good to come back. Morning. Thanks, Ramesh, for getting me back to my place. So, uninostril versus binostril. Recently, again, some discussion started on going back to uninostril if it is not required, and small tumors go back to uninostril. So, I just try to answer some of these things. So, this is my work here in 2005, 2006, actually. This is the case of macroadenoma. Same. I used to do uninostril only that time because I was alone. I was not comfortable with the binostril. Nobody had the experience of a hand-eye coordination on this thing. So to make my life comfortable, I used to always put a speculum so that the repeated soiling of the scope doesn't happen, and then go in and remove the tumor. This is of 2005 and 6. This is the case of a macroadenoma. This is the case of a Cushing's. You can see the patient's face. Same right side going. There is slightly clarity because of old videos. And removing the tumor. When we presented these things, people are not comfortable because at that time microscope was still in 2005-6 was still the in thing. And same method, nothing has much changed in the approach for pituitary adenomas since then, except the extended external endonasal and the extended skullbase approaches have that same. But the standard pituitary is there the same. The only thing to make the vet comfortable, I used to put the speculum so that you get tired with the repeated soiling of the scope coming in and coming out, you keep on washing and irrigating.
Please.
So this is the patient's pre-op. And this is post-op done. This is, you can see the date here, 2006. This patient has done, scan was done. Some residual tumor in this, around the cavernous sinus. We didn't know the extended transcavernous in 2005, but we are slowly learning. In cases of pituitary adenoma, besides the adenoma, there are a lot of other things. Olfactory changes, changes in mood, appetite, sleep, sexual desire, social interaction, everything. So when you go for a transnasal transsphenoidal surgery, you should not add morbidity to it by any method, so that patient doesn't have this additional burden of discomfort. So surgical approach, does it affect outcome? Binostril approach, is it for all? Uninostril approach, is it sufficient? Hazard flux for all, is it an overkill? So these are some of the points I will going to address in just a standard review of literature I've done over a period of time. The SNOT score is a standard thing which is available widely of the thing, and it's an extensive assessment you do regularly whenever the patient comes in. And based on that, you grade the outcome, comfort and discomfort. It's a very standard thing, well accepted all around. Some modifications are there in this, but it's a standard thing. So these are some of the things which you see in the nasal anatomy, the crusting, the synechia, these things. The postoperative nasal cavity nursing is an important factor in promoting healing and rehabilitation of the patient. This is what we as neurosurgeons tend to neglect it. Okay, because the patients come to OPD, we don't have facilities to take the nasal wash and nasal caring. So tying up with ENT is an always beneficial something. And before discharge, the patient should be repeatedly instructed on doing nasal irrigation. They should be taught nasal irrigation when in the these things. So one of the major aspect is the loss of olfaction actually in many early things. So the olfactory receptors are mainly distributed in the upper turbinate of the nasal cavity, mucosa between the nasal septum. So any damage or excessive use of cautery around that area will affect the nasal outcome. And especially these things happens when you do a binostril technique. So these are some of the literatures I'll be in the series. I'll be reviewing it, and this thing is a. So this is a chronic nasal complication following endoscopic and microscopic pituitary surgery. Higher incidence of postoperative impaired olfaction seen in microscopic approach because it was considered a speculum used to pull it out. When you open the speculum, around the superior turbinate gets damaged sometimes, and the medial wall gets in. So in those cases, the olfaction gets impaired more. So importance is strict adherence to landmarks. Olfaction descent patient pituitary adenoma. This is a big study, a qualitative study. The widespread occurrence of impaired smell and nasal function in patients with pituitary adenoma after endoscopic transplant surgery. Recommendation is intensify post-operative nasal care. So post-operative nasal care also plays a very important role in preventing these smell problem. And olfactory training methods to promote improvement of olfactory function has to be started early in the post-operative period. Olfactory and gustatory outcome following endoscopic hyperoscopy. And in this series, they didn't say transsphenoidal surgery affecting any overall sense of smell and taste. However, the subjective olfactory quality of life and ability to identify odorants are affected. So there is an element of loss of olfaction. There's this article came out in neurosurgery in 2015. Long-term results of endonasal endoscopic transplant infection of non-functioning pituitary adenoma. Alteration in smell was found in 13% of cases. So though above systemic, we could find that olfactory damage was more common in the binostril group than in the urinostril group. However, the number of studies relevant to the olfactory damage was rare in the mononostril group. So they postulated that olfactory damage was not common complication of the mononostril group. It's more common with the binostril group. This is when a single neurosurgeon does this and when a team of neurosurgeon and ENT surgeon do it, what is the outcome? And it was seen that the group 2, when you collaborate with an ENT surgeon, the outcomes are better because the post-operative care, the dissection is better. So you can have always a collaboration with them. If you are confident enough, please go ahead. But post-operative nasal care is equally important in these cases. Extent of surgery in endoscopic transplant surgeries can affect the sign morbidity. Here, the worsened after the thing. This article tells that there's early loss of olfaction and nasal morbidity is there, but in the long term, urinostril and binostril doesn't matter. The long-term outcomes are same in both the cases. This is very important. Effects of nasal irrigation after endoscopic transsphenoidal dissection patients with pituitary adenoma. Nasal irrigation helps in reducing the incidence of complications such as epistaxis, nasal adhesions, synechnias, and it can also promote the elimination and reduction of olfactory disturbance. So we should not neglect this. So for us in our patients, in the early post-operative period, by the second post-op day, we teach the patient before discharge how to do a nasal irrigation. If there has been no CSF leak and these things, after the pack is removed, we teach them how to do a nasal irrigation and with that they are discharged. Comparing mononostril, binostril, 1.5 nostril techniques after these things. So this is the mononostril. We can do it for small tumors. The binostril for extended skull base and large tumors. And 1.5, when it is not inadequate, you have to just do a posterior septectomy to remove, introduce one instrument. So practically what we talk of binostril for a practical sense, actually we are doing is a 1.5 nostril, not a binostril exactly. So I went into the binostril technique of doing things, looking at both mucosa, and just run through the video part. This is standard steps, identifying the molar. You can see that one of the instrument is through the opposite nose. Two instruments are through the ipsilateral nose. The scope and the drill is done, and the suction is from the opposite side. Or we take the scope from the opposite side and take the suction and the instrument from the same side. So drilling out, and then using a scissor to cut. Laterally, when we cut laterally, we usually don't use the knife. We use the scissor, actually, the angle scissor or the microlaryngeal scissor, so that we can dissect it below the dura and then cut it to prevent any injuries to the carotid and the cavernous. Then suction standard method. packet with fat and some gel form. And ultimately inspecting, this is the opposite side nose. We have not done anything except this septal window we have created. So this is more of a 1.5 technique than actually a binostril technique, because nothing else we have done in this case. In this tertiary, the result shows that the uninostril achieved the same surgical outcome as the binostril technique. And this is again one more repeat versus the, and they found that the binostril approach has less temporary diabetes because when we go for a binostril, they tell that the excision part, when we look at, is adequate. We are able to see the tissue better. We are able to excise it better. Sometimes that may be a problem when you approach large tumor with uninostril techniques. So you should not do that. Now comes to the use of Haddad flap. The different types of pedicle flaps are available. Should you use Haddad flap in any small drop of thing? No, you do not use it. And so here they're saying that early and late posterior angiochromic rate after PGD and risk of coronary harvesting may be important factor in optimal process. So in Haddad flap, harvesting adds to the morbidity. Yes, it prevents in good healing and preventing a CSF leak and these things, but that can also add to the morbidity. That has to be kept in mind. So many of these Japanese surgeons, if it is not only for extended skull-based surgeries or extended surgery, they take a Haddad flap. Otherwise, they are still comfortable using the fascia lata and the fat and fascia lata grafts actually. Again, this is they're telling that use of these Haddad flap and this thing increases the sinonasal morbidity. In this paper, there's a cranial-based reconstruction using muscle and fascia lata seems to be a potential factor positively influencing the outcome and quality of life. So if you can use the thigh, the quality of the nasal quality of life is better instead of when you are using a Haddad flap. But if you have to use a Haddad flap, if you are excising the middle turbinate, you have to do the mucosalization of that bare area with the mucosa of the middle turbinate. That is also can be done. So that decreases slightly the morbidity because you have bared the nasal septum for taking a Haddad flap. If you have done a middle turbinectomy, take the mucosa of middle turbinate and cover it over the bare area of the nasal septum. So this is again a simple pituitary adenoma. So as I told you, where I started uninostril approach, but now things that I don't use a speculum and anything, I'm more comfortable, more hand-eye coordination and learning of the anatomy is better. You can just have a uninostril technique, but removing these type of simple tumors. You don't have to do any binostril technique for removing these things. A comfortable case and these things can be done. So this is a post-op scan. So use of uninostril approach, preservation of middle turbinates, avoidance of maxillary enterostomies and avoidance of raising of nasal improve the immediate post-op outcome. Long-term outcomes will be same. Doctors should recognize more point of attention during nasal operation, while nurses will also have more specific for the post-operative nasal care. That's the equal responsibility of the doctor also. And early nasal irrigation for all these patients help in improving the post-operative outcome. Thank you very much.
So got the excellent talk. I think we are going to take the questions at the end. And I call upon the next speaker, Dr. Naveen, hearing views on lateral recess approach to the CSF anuria.
Good morning. I thank Dr. Ramesh, especially for giving me this opportunity and Neuroendoscopy Society of India and presenting my topic. I'm its neurosurgeons. I'm really grateful to share the podium. Thank you. So this is a case of recurrent CSF rhinorrhea with a defect in lateral recess roof of sphenoid sinus. It's a case of 55-year-old female presented with right-sided watery discharge for past 3 months. We have operated this case in 2018. Beta-2 transferrin test was positive for CSF. She underwent surgery prior to this our surgery. That was in 2015 and 2017. It was first time it was transcranial, and second time it was transnasal. So plain CT PNS, coronal cuts showing previous surgery signs, burr holes and defect in the roof of the frontal sinus. In CT cystonogram showing the escape of contrast into the right lateral recess roof. Yeah, there are 2 defects here. I'll be demonstrating in the surgery. The plan of surgery is transnasal endoscopic closure of the leak. So these are the basic steps when we approach the lateral recess, like uncinectomy, wide middle meatal antrostomy, which I'll be showing. So in any case, what we do is the first basic 3 steps, that is first pass, second pass, nasal endoscopy, and third pass. In the first pass, this is the first pass of the nasal endoscopy. Directly, we can visualize the sphenoid sinus where previous surgery was done. And then the lateral wall, we can see the meningocele. This is the septa between the right sphenoid sinus proper and the lateral recess. So initially, I trim the middle turbinate. Then with the powered instrument, I'm trimming the middle turbinate lateral aspect to widen the space and also help me to increase the workspace for the endoscope and the powered instruments. So with the micro debrider, I'm taking out the uncinate. That's the mucosa of the uncinate is removed. Then widen the maxillary sinus ostium. And these are the basic steps to go into the anterior ethmoids. The first lecture was fantastic about middle turbinate anatomy, where the 3 parts, crucial middle part and the posterior part. So this is radio frequency probe, which is a very handy instrument in getting the hemostasis achieved in every step of your sinonasal surgeries. That's the superior turbinate. Once the middle turbinate is removed, so I'm removing the middle turbinate to expose the ground lamella. And once the ground lamella is punctured, then we enter into the posterior ethmoids. This is the superior turbinate. Lateral to superior turbinate, we will have posterior ethmoids. So there's a posterior ethmoidal layer cell. This is the sphenopalatine foramen area where we encounter the major branch, that is the sphenopalatine branches. And I've widened the just showing how to encounter the bleeders in this area. So instead of diathermy, I use radio frequency, which has bipolar as well as a long ball probe, which will be very handy in encountering the bleeding. So that's a Garrison sponge, which is used to widen the anterior wall of the lateral recess to expose the meningoencephalocele. Then I am using a drill to widen the anterior wall as well as the superior part of the wall, so that we get good exposure of the lateral recess. So here we have to be little careful not to use debrider because I have encountered a major bleeder there. So that's the posterior wall of the maxillary sinus, which is an access to the pterygopalatine fossa. So this approach is used for cavernous sinus approach. This is the major branch from the sphenopalatine. And we get posterior septal artery in the anterior wall of the sphenoid while we do wide sphenoidotomy in cases of transsphenoidal approach to the Sellar. Then once you get good achievement of hemostasis, then widen the lateral recess, then debulk the meningoencephalocele. This is all occupying entire lateral recess on the right. Again, there's one more bleeder there. This is a nice exposure where I've debulked the part, anterior part. We can see the pulsations. Then debulk up to its origin to the base. Yeah. So those are the remnant at the base. And two neurosurgeons were with me while I was operating this case because it was referred by them. Now the closure part. I've closed it with fat globules, then tensofacial artery. Then I created a mini Haddard flap, which will give a good blood supply to the fascia. That's how I'm harvesting the flap. Again, here I'm using radio frequency. The advantage is its lateral heat generation is less. And instead of diathermy, where if we use diathermy towards the superior part of the septum, olfaction disorders are more prominent when we use diathermy. Then 2 layers of facial artery I've used. Then proper covering it. Then I've applied rotated the mini Haddard flap. Post-op patient did very well. Then on top of it, I use Surgicel, then tissue seal, then Merocell packs. 5th day is the time where we remove the Merocell packs. So, this is the external picture. So here, cranial encephalocele, they are the herniation of intracranial meninges and brain tissues through a defect in the cranium or skull base, which are rare conditions. Incidence is 1 in 35,000, more in the anterior cranial fossa than in the middle one. Basal encephaloceles represent up to 10% of them. Intrasphenoidal encephaloceles are rare. Medial or parasellar type arises from the superior or posterior wall of the sphenoid sinus. Lateral localization, which results from temporal lobe herniation through a middle fossa defect into lateral recess of sphenoid sinus, is even more rarer than the medial localization. The least common type is the basal encephalocele. I'm not going into details of pathology and etiology. So this one is called as Stenberg's canal. It's all about embryology of Stenberg's canal. Stenberg's canal has been reported in up to 4% of adults. They found the development of arachnoid pits in the lateral recess of sphenoid due to underlying intracranial hypertension was a major cause of acquired spontaneous CSF. Yeah, few studies have revealed leaks medial to foramen rotundum. Multicentric combined clinico-radiological meta-analytical approach probably serve as a solution to this controversy. These are the references. The plan of action steps I have already described. So always discuss the case with your mentor 1 day prior and discuss with your colleague neurosurgeon before starting the case. What is your plan? And always combine the plan. Don't hesitate to take the help whenever needed from seniors. And follow-up of the case is most important. I thank my professor and chief, Dr. Deendayal sir, my colleagues at my center, Sphenoid Hospital, and Dr. Deendayal CNT Care Center. Thank you.
Thank you, Dr. Naveen, for an excellent demonstration. We call upon the next speaker, Dr. Ayadure, to share his views on Planum sphenoidale meningioma, the best approach to Skullbase. Okay, sir. Okay, sir, we'll take it. Dr. Naveen, there's a question from Dr. Chasti, sir.
No active CSF leak has been demonstrated.
Sir, the speaker is in front of you.
Okay. No active CSF leak has been demonstrated in the surgery you have done. The pit was there, but there is no CSF leak. So how are you sure it is only from there you are getting the CSF? No, but at surgery, we normally in a CSF leak, when you go transnasal to seal, you see the active CSF leak. Sometimes we will ask the anesthetist to give Valsalva, and then you'll see the CSF leak. But you have not seen any CSF leak. Well, yet you have not demonstrated. Thank you.
The pre-op scans of patient, is it the sternum-bugger leak, what you said this time? Did you cross-check with the other scans? Is it the same site or what was the, how do you explain that?
There was one different.
No, it's my concern. No, I think you would have reviewed because before labeling as a failed to boost surgery, means the two surgeries we think it is a failed, right? Is it a new defect or it is the same defect? That is also not clear. And I think that you would have put the pre-op scan and the post-op scans, and then before your third time surgery pre-op would help us.
Thank you. We'll move to the next. Ayadure, please.
Very good morning to all. I'm the old new kid here, like I've recently joined in Yashoda Hospital. It's a senior consultant in Secunderabad branch. I hope we, myself and Hyderabad both adapt to each other pretty well. Thanks for the opportunity, Ramesh. Planum sphenoidale, it's anteriorly continues with the cribriform plate and posteriorly it's limited by the limbus sphenoidales, like the limbus sphenoidal finishes the planum sphenoidal, and laterally it continues as the lesser wing of the sphenoid. So this pic makes a lot of anatomical significance, though it is from the microscopic perspective. What we are going to drill to expose this area is like on the whole of the ethmoids to get a clear vision of the planum sphenoidal, the limbus sphenoidales, and the prechiasmatic sulcus, including the tuberculum cellar, to have a good visualization of the pituitary gland, both the optic nerves, and if required, to open the optic and the dura overlying the optic canal for the tumors which extend into the optic canal. I'm sorry, I don't have the MRI pictures. This is the tumor which is marked here. Now, this is the planum sphenoidal area, and then it is extending up to the tuberculum cellae. It's got a lot of hyperostotic changes and then dilated to the sinus also. We even had a doubt whether this is an pneumosinus dilatans, but then it's more commonly seen in the frontal sinus, but this is here in the sphenoid sinus. As such, the sphenoid sinus is very small here. So We decided on doing a transnasal, transtubercular transplanum excision of this meningioma. This patient is an 60-year-old presenting with the visual compromise, more on the right side. So it begins with the robust basis of a flap harvesting. Sorry. This is largely the initial 1/3 of the part, like, the beginning of the surgery, like, it is all done by the ENT surgeon. We have to have a good ENT surgeon. That was. That's the initial look of the sphenoid sinus. That's the exposure, like, which Dr. Subodh was talking about, like, the 1.5 transnasal technique, like we just expose the postseptum on the opposite side. This is extending into the uncinate process to get into the ethmoid sinus to clear it, like, the whole of the ethmoid has to come out to have a good exposure of the sphenoid sinus. And here we see the keel, and then, like, now the keel is being removed here. We just had the look of an owl's eyes there. Once if we remove this, then we get a good exposure of the sphenoid sinus. Though we see this picture of the sphenoid sinus, like, the familiar anatomical landmark, what we can see is, like, here probably this is the optic nerve here, and then this is the carotid prominence on the right side. And big thick ridge is running over the carotids on the right side, and then, like, the rest of the landmarks are not very distinctive here. So continue drilling, go slow by slow, because of the meningioma, the bone is very hyperostotic. You have to be very meticulous, you have to be very careful. Use the navigation, use the Doppler, and this is the navigation which we are using to locate the structures. Sellar, and then, like, we go and then drill the base of the clavicle creases also for the flap to get adapted. This is a Doppler being used to identify or trace the carotids, and that's the drilling starting from the limbus sphenoidale to the drilling of the planum. Here we are drilling in between the carotid to carotid, or, like, the tuberculum region. Make a slow boots or very thick bone. You have to slowly progress. That's a pre-chiasmatic sulcus, like, we are drilling. Unless we drill this and then, like, remove the MCRs on both sides, like the middle planets on both sides, like, we will not be able to free the tuberculum cell. That's the removal of the middle planar process. Like, now here we have the optics and the carotids below. Once the extent of the planum sphenoidal meningioma is identified, then we cauterize the dura. You want to pause here for a minute. Like, this tumor was very fibrous. We had opened the dura. We had to open the dura itself. Like, we had to use the angle to true cut. And here, like, we have identified the arachnoid posterior to the tumor here. So we create the space and then slowly advance, and then leave a patty as soon as, like, you get a space in between it, like, to prevent damaging the structure which is behind us. This is again the angle through cut which is used to cut the tumor. With the great visibility, like, we try to preserve the arachnoid over the bracels. Like, this is where the ACOM is coming into the visualization here. Always keeping the structures behind us, like, and then we have to utilize handle the instruments very carefully, not to catch up any of the structures behind us. Or we have to run the instruments only under the vision. And this is the left Hubner is being relieved of the tumor capsule. With the monoshaft instruments also, the micro dissection, standard microsurgical dissection is possible. Only other way is to, like, decompress, remove it by slowly, piece by piece, and then that's the right optic now. That's this talk. What we're seeing, like, this is the chiasm here. This is the optic, the stalk. Pituitary gland is here, and then that's a PCOM. We see the third now runs here, and then that's a basilar top with the ACS. That's the third now we are seeing. And then on top, like now we are seeing the third ventricular floor and the ACOM complex. So towards the end, like now the tumor which goes into the right optic canal is being delivered out. The whole of the right optic now gets filled up. That's towards the end. Give a lot of wash to clear up all the arachnoid blood, and then standard reconstruction. The fat followed by duragen. Duragen will have to be proper inlay, and then followed by the onlay graft of facial lata. Then if required, like the space is more to accommodate the flap, like we can leave more fat on the facial lata, which is the nasoseptal flap, which is covering the whole of the surgical site. That's a postoperative scan. We can see an olfactory groove, like now there's a small meningioma there, which we weren't planning to chase it. And this is the residual tumor, like it is remaining there. That's an intact stalk and then pituitary gland, and then rest of the tumors which was causing compression onto the optic nerve and chiasm was relieved. Patient had a good visual outcome. This is our team, like now Dr. Jani, who is here, like we'll be giving a talk in the evening. Dr. Krishna Tej, who was joined me as an associate consultant with me in Ashoka Hospitals. So what I have marked there is like, now this is at the end of an transnasal excision of an decompression of the pituitary meningioma. So at 7 hours, 30 minutes, Johnny was the lonely warrior, like who was standing there. I probably was there for about 3 or 4 hours. Developing a good team with the ENT surgeon, very important to become a successful endoscopic neurosurgeon. Thank you.
Very good demonstration, Yadire. May I call upon the... Okay, sir.
Nice surgical skill, but I want to clarify one point. Yes. There's a Sellar meningioma, small one, and there is no much frontal sinus. Normally, when we try to do surgery for these lesions, we are worried about the frontal sinus, quickly open the frontal sinus or not. Here, transcranial is not touch the frontal sinus at all, but having gone transsphenoidal, we have to remember the whole ethmoid sinus, sphenoid sinus, and everything. What is the great advantage of this? It is a very small tumor. Transcranial could have been done without much retraction and without much problem.
So I agree with you, sir. Like now the visual outcome was a prime concern here, and the infrachiasmatic dissections and then dissections over the pituitary glands, I thought like it is probably a little bit superior compared to the microscopic approaches in the endoscopic, because it is under direct vision and the visibility is much greater compared to microscopic. It is possible, sir. I agree with you. Like it is possible with microscopic dissection too.
Yeah. But most important anatomical structures, carotid artery and optic nerve, you are seeing at the end of the surgery, not in the beginning of the surgery at all. Again, that's the important thing one has to keep in mind when you are operating on those lesions.
Agreed, sir. Microscopic approach, like we are going to go on the top of the optic nerve, and then like we are going to go in between the carotid artery and the chiasm also, or optic nerves too. Here it comes in the last, I agree with you, but then like now they are far away and then like we can dissect it off safely, sir. Thank you.
Yeah, I call upon Dr. Manas to share his views on endoscopic approaches to CV junction.
Good morning. I'd like to thank Ramesh for Dr. Jalil for taking the effort of organizing this meeting and asking us to participate in this. As Professor Sastry said, like, one has to know the
If your hand is like this, it puts a lot of strain. If I'm, here resting here, then it's slightly comfortable for you. Okay. I don't have to mention this to ENT surgeons because they are used to it. I'm telling it for neurosurgeons only. Okay. Who are not used to doing routinely endoscopies. So you can see the ala of the nose. Okay. Your scope should be resting here. Okay. Number 1 point. The instrument should guide the scope, not the scope should guide the instrument. Then there will be soiling. So the instrument should guide the scope. So irrigation though, irrigation. Inside, irrigation. Inside, yeah. There's a lot of trusting with saline. It is light source. Gone. Light on the right. So whenever the light goes off, you take the OT light. Keep on putting saline. Put saline. Keep on putting saline. Give and put sir. Saline. Some more saline. No light. White balance करना है इसमें? Okay. So this is the right side. So when you enter, what will you see first? Hypertrophic turbinates. This is the left side. Whenever in doubt, where do you go to? Whenever you lose anatomy, which is the place you will go to in endoscopy, nasal endoscopy? Yeah. Every time go to the choana. So we'll remove the mic, I think.
No, it was very close. Now, sir?
Hello. Is it clear? No. Echoing. Hall is like that. I think without the mic is better. No? Hello. Back. So whenever, better, no? Yeah. Whenever in doubt, and this, look at the camera. To get the anatomical orientation, it should be always like this, top bottom, so that you have the anatomical orientation. You can move your hand like this also, no problem. But this should be fit. The camera always tells the orientation correctly. Not a great nose dissector though. Flat dissector. Oh, there. Right. So you can have this flat dissector to lateralize the middle meatus, or there is a dissector available with suction. You will find it routinely in any ENT setup. Take that actually, very useful. Lateralizing. No, wait. Just we have not gone inside, huh? Yeah. I'm just cleaning. My work is cleaning now only. Chalain. This is the mid turbinate. Okay. This is the big inferior turbinate. And the first part I'm doing just Routinely, you don't have to do a turbinectomy, but in this case, I will not waste time in this course. You just remove the middle turbinate. Hey, too much of echo again. On क्या क्या? अच्छा पीछे वाले को साउंड नहीं आ रहा है क्या? सीजर है? नहीं ENT instruments are there, huh? Caesar. नहीं, the hall is like that. That's why the echo is. और दूर कर दो. हाँ. That much is sufficient. Hello. The basic Ramesh. नहीं रमेश कहाँ गया? रमेश चलाएं. आज सीजर का दूँगा. चलाएं इनसे. हैं? Yeah, why is saline infecting another? You don't have to repeatedly remove the scope, no? So this is the corner, okay. ठीक है. This is the superior turbinate I showed you. This is the superior turbinate here, okay. I am waiting for the Caesar to do a middle turbinectomy. So you can do a partial or a complete middle turbinectomy if you require. The space is less. So this is partial. This much is sufficient. You can leave the superior part.
So remove it completely or keep it pedically?
No, you pull it down, mobilize it down. Okay. Yeah. Keep on pulling that down. People do uncinectomy also. so that they get more space to lateralize the middle turbinate. If you don't want to actually do a middle turbinectomy, the uncinate bulla slightly deviates the middle turbinate. So just do an uncinectomy and further lateralize the middle turbinate.
Is it regular for extended approach?
No, not required. Not for every case.
Extended approach is also not regularly.
Extended means whether you want to do lateral.
Yeah, lateral.
Lateral में जरूरत होता है because you require that angle, not for anterior. And as you do more and more, you realize that these are all things are not necessary. Initial phases, yes, we all went through that phase, as Dr. Manas told.
Yeah.
Come here, my sister, take out the dustbin and stand here. Shall I? I have the luxury with me of a divider of our own. बड़ा instrument है. Ideally, it comes out in a piece if you remove the middle turbinate properly. And that mucosa, as I was telling you, some people use it. Okay, you got some more space now. Okay. This could be the ostium actually. You can see here. Okay. So middle turbinatectomy is not a rule. It's an option. Shall I? That could be the ostium here. Okay. The forceps is right. In this case, I did it because I didn't want to waste time on. Okay, now you got spaces. Good. Section. Yeah, you can see the ostium here. Okay, this is superior turbinate here. Now what we do is for identifying the vomer. So junction of the septal cartilage and the keel of vomer. Okay, that is where we go and infiltrate. So the mucosa automatically gets separated. After so here you will infiltrate all round, okay, and then take a. Okay, what is the danger if you go too high? Olfactory. So you have to be very careful while using cautery in the superior part. You can damage the olfactory and don't dissect also, because then there will be post-op adhesions also. Wherever you use your cautery or your dissector, there will be adhesions. Sickle knife. So whenever you get lost, go to the corner. This is the corner. Okay. So approximately 1 to 1.5 centimeter should be here.
You use a knife for reading the
For this thing, removing the mucosa. Either use the cautery or use a sickle knife. There's sickle knife here. I saw it.
If there is any bleeder, they stop with the monopolar.
The curved ball tip monopolar or this thing. ఇక్కడ ఉంది sickle knife అని చూసాను. I saw the sickle knife. No. Okay, you can see here mobile part and the fixed part. Okay, just feel it, you know the junction. So here another important step is, once you do that, if you are doing that 1.5 technique I told you, you create a septal window on the opposite side that is just above this here, this area. So for that you take a back bite and do a septal window. Or if you want to introduce one more instrument on the other side. So infiltration at this part is very important. And what is the vessel which will come here? Septal branch. That's leading. You have to be careful on that. So you can coagulate that portion and then do it. Give the Caesar. ఇక్కడ ఉంది Caesar. Dissector. Dissector. Flat dissector ఉంది. First use చేశాను. So this position is very tiring. So if I raise the head end, it becomes like this. Small things, very helpful. Okay, you can see the movement now. The question is, should you keep this mucosa? You can debride it. You can debride the mucosa completely. This is the opposite side. Okay, dissected both the sides. I'll cut this portion. Just give me time. Okay, both the sides. This is the keel of the wormer. So this mucosa which is there, there's an option of keeping it or you can debride it. But less of cautery again. More cautery, more crusting. So what the ENT people use is a cobblator. That is good. That produces less scarring. Thank you. So I use a suction dissector like this, so it's very easy to get your job done. Okay. So this part you have to be careful. As I told you, the septal branch will come. So if you want to coagulate that, you can cut it and coagulate here. Can I have a Caesar again? No, that other Caesar. ఇక్కడ ఒక Caesar ఉంటుందా? Micro. It's okay. Take it. This is not reaching actually. This is not reaching. This is too small. Stay right. No, I'm just cutting this small part. No. This small part cut. That Caesar is not reaching there. Sure. That.
You don't have a cautery here, sir.
No. I don't think we have a cautery here.
Doing a posterior septal pushover technique.
Posterior?
Posterior septal pushover technique.
Septal?
Pushover.
Pushover. Drill ready, yeah? Drill. No, not ready. Section. Okay. You can see the sphenoid osteum here. Okay. On this side, sphenoid osteum. See if the other side also it's here. It's not seen. Shall I? I think first part I will break it off. I don't require, the drill is required, wait. This is not very hard bone, unless you are in a acromegalic patient, where the bone is very hard. Shall I? Put. Yes, that's all right. Now I can require the drill. Drill. It is diamond, huh? Chota? That's working. So when you are using a drill, don't take the scope too near it, because it's repeatedly fogging and dust will fall. So keep it slightly away. Okay. So at this stage what I do is, I take an infant feeding tube and place it inside and connect it to a suction. So even if you are going from a uninostril technique, everything which is getting collected in the dependent area will come out. Okay. This is I am drilling the vomer out, the posterior part of the vomer. Anterior part will be soft usually, but posterior part will be firm. Yeah. Irrigation is for cleaning the scope and for the dust to this thing accumulate, and that infant feeding tube judge which is placed behind, it keeps on sucking out. This could be the septum of the sphenoid sinus, okay, and this posterior part drilling is very, very important. Reason is, otherwise you don't get an angle to the anterior part of the sellar, unless this posterior part is drilled. You will go straight like this, but this one instrument will not turn like this. So this completion of this drilling at this portion is very, very important. It may be 5 millimeter, but that angle is very, very important to you.
What's the landmark to stop the lower border drilling?
The clivus.
No, not inside the sphenoid, the vomer.
The boomer. You can see the, you have to see the clivus and the sellar trough, the sulcus or what do you call it? Recess. Sorry.
How much lateral this mucosa has to respect?
This one. Sphenoid ostium. Both sides sphenoid ostium. Again, if you are going to go slightly more laterally to the cavernous sinus, you drill it side more laterally. Okay. Otherwise, sphenoid ostium is sufficient, both sides.
So how do you manage space laterally? When you do a turbinectomy for that? Because the middle turbinate comes in
No,
that way.
not required.
Just lateralization.
Just lateralization is sufficient. 90% of the case. I told you, the initial part of your surgery, you may require to do a partial middle turbinectomy, but as you keep on doing it, you will know that it's not required. Look, middle turbinate is here. Okay. Your angle is from here. It doesn't really matter. Maximum you have to do is a partial middle turbinectomy.
Is the posterior part you're drilling?
Yeah, posterior part of the vomer. Once I thin it out, I can take an upcut and do the rest of the job also. Wait, I don't have the suction inside, no, that's why I'm not. Yeah. So when you want to create a small septal window, no? So what we do is we take the suction here, introduce this opposite side, where it is bulging onto the mucosa septum. Just apply a cautery. A small septal window is created. You require one instrument from opposite side. It could be a scope, it could be a suction, it could be. Those are two main things actually. Other working instruments you require it in your hand. So what I was telling, it's more of a 1.5 technique than a actual binocular technique. Saline.
So uninostril 1.5 also we have to prepare the other side also.
Not required. Pure universal में जरूरत ही नहीं पड़ता. जैसे अभी तक मैं have I prepared the other side? I didn't do anything on the other side. But I'm seeing both the sides, na? More saline, more saline. Yeah, keep on putting saline.
Sir, once you drill the posterior part,
No, yet I'll keep on asking.
then how to maintain it in the midline? Now, now since we have a sphenoid septum, we know that we are in midline.
No, sphenoid septum necessarily will not be in the midline. So sphenoid septum is never a guide for midline. Your vomer is this one. You can see this one.
By the time you drill, you would have opened the sphenoid sinus, you know how much.
How much you?
The Sellar you will
If you have neural navigation, that's fine.
just see the heel without seeing the. So as soon as we open the sphenoid, we should keep up the mucosa to see the landmarks and
We should?
sphenoid mucosa
No,
study.
no, not required. Finish your drilling part. Okay. Finish your drilling part, then you have to take the mucosa. For this case, I'm just taking out the mucosa because I have to drill out the septum also. Okay. So how do you remove the mucosa? Blunt dissection. Otherwise, take a cautery, move it around the mucosa. It will just test out, it easily comes out and there will not be bleeding. If you just try to remove the mucosa, then it is bleeding.
What if it is a dehiscence?
Monopolar cautery लेके अंदर में, ball tip monopolar cautery, just move it inside in the mucosa.
So what if there is a dehiscence?
Huh?
What if there is a dehiscence? Pre-operative radiology is there.
Dehiscence. That much you will know. If you don't know that there's a dehiscence or not, then
It is a must.
Because I do a CT. Because navigation करते हैं हम लोग तो use करते हैं.
You don't take heart flap or
No, never. I didn't discuss extensively because time limitation. Many of the people have, in routine cases, they have gone away with the adult flap because the nasal morbidity is again more in her. Opposite side. They said if you have already cut it, take the opposite side.
that is take it out in reverse.
Reverse.
Does the septal window? It will come out from this one only. This way.
Yeah. Yeah. 90% of your routine leaks. No. इको आ रहा है. दूर करो.
पर उधर ऑब्जर्वर को सुनाई नहीं दे रहा है. वहाँ पे पूछ रहे लोग. ऑब्जर्वर को सुनाई.
90% of your routine leaks, you take a fascia and fat, that's sufficient.
I'm just asking, supposing you are putting opposite side, this is the point where we will come out and then.
Yeah.
Because we have formulated already that sphenoidale and rectified from this side, we cannot take the.
Yes. Okay, I'll remove the septum also. So this is the recess I was talking of.
This is the saliva
Drill. I'll do that. I'll do that. Just a minute.
Any other technique to remove a septa other than drilling?
No, take that forceps and break it. If it is, I have the luxury, and that's why I'm doing it. Again, I told you, if I am giving the camera to the opposite nose, then I give my assistant. My assistant will hold the camera. If the camera is going from the opposite side, if the suction is going from the opposite side, my assistant will hold the suction.
What do you prefer, a bimanual or a?
1.5.
1.5 means you are doing you're using the camera in your hand or the assistant? Yeah, suction. And then the scope who is holding? You are holding the assistant. For your case.
If I am giving the scope from the opposite side,
For your case, sir.
for my case, I hold it.
You hold it. Bring the camera from
So, in very difficult cases where I have to dissect the capsule, then I give then I give the camera to my assistant because I require 2 instruments in that cases. Saline, please.
saline. So this is the point I would like to remove the mucosa completely. Dissector? A flat dissector? Yeah. Sphenoid mucosa. This is the Sellar. This is the Sellar. Thank you. Wait, I'll show you some more things in this. Okay. So here I can use the cotton. Okay. My suction is from here. Or you, 1.5, 1/4. 1.5 से do a posterior complete septectomy. Create a good window. Can I have the drill? You can use the suction from here. Huh? You can put saline. Suck. Block हो गया क्या suction?
Suction ठीक है.
Saline. Suction block है. ये machine से block है. ఇది ఫ్లష్ చేస్తారా కొంచెం? That is where we park our suction or your infant feeding tube, in the recess beyond the cellar.
Suction वहीं पे स्लाइडल वो डिपेंडेंट एरिया है वहाँ पे
चलो suck again, block, huh? What I'll do is, this is the end of it. I'll separate the mucosa and show you the anatomy first. Okay. Then opening the cellar later on. First, everyone will do this much part. Then we'll do the later the opening of cellar and this. Okay. I'll remove all this mucosa and it's easier. What is that? This scene. Sphenoid. Sphenoid तो क्यों दिखाता तुमको? What is this? This is also carotid distance. This is the optic nerve. This is the carotid. Okay. Here it will be this one. There is some more restriction. I can remove this part. Up cut it. One by one. You can use an upcut to remove this also. Huh? Saline. Drill auxiliary. Now it is clear. The planum will be here. Okay. This bluish thing should be the intercavernous sinus. Give me the drill. No, drill. 1 minute. Just drill. Without suction, no saline. Okay. Now give me the dissector. Angle scope. So your carotid will be here. Okay. This is the optic nerve.
Yeah.
This is the planum. This is the clivus. Dissector. Sorry, angle scope. 30° ఏదైనా ఒకటి అండి. ఏదైనా ఒకటి 30°, 45°, whatever is fine. ఇది 45 ఆ?
37.
Yeah, towards the left side. I just want to show the other side. It's not mandatory to see in every routine pituitary case because it's a demonstration. I'm sure. Angle dissector ఉంది ఒకటి. This is the optic.
Lateral.
Yeah. This will be the recess here. This one. Old person, a slight flattening will be there. No issues. The septum is deviated more towards the left side in this case. Okay.
It's still sitting on the cellar.
Yeah, this is the cellar, no? Complete thing cellar. This one didn't remove it completely. That will drill. This is the cellar. This is the septum.
This one.
This is septum.
Below the septum, isn't that the cavity?
Part of the septum only.
Part of septum only.
Yeah. Oh, I breached it here, I think. ठीक है, breach हो गया. Sellar ने superiorly part at the junction. Weapon, you please. I'm just. Saline inside. That's all. So everyone can proceed now. This much is now opening the cellar for later on. Okay. Simple thinking. Don't go into very complicated thinking. Mike. Hello. Request everyone, whoever is using the drill will not use the drill without the faculty around. We have enough scopes getting spoiled by drill. So nobody is going to use the drill without the faculty around. There is one faculty allotted for each table. So please be careful while using the drill. The wormer can be removed by the punch and the upcut also. It's not mandatory that we have to use a drill. Okay. If the faculty is around, under supervision only, the drill can be used.
So if every table has a name A, B, C, D, E. Each people check their names and slot, and please go there, and the senior faculty will join, and you start doing. It's already 12 o'clock, so everyone can take hands on and start taking turns. You in turn take turns inside.
Hello, check. Hello, check. Check, check. ఇప్పుడు
Hello everyone. Lunch is ready. If in every table, if dissection is done, half of the people can go for lunch and half can continue for the dissection. The, the persons who have already completed your dissection and each table can go for a lunch and come back so that the other people can do meanwhile.
Check. Check. Check.
జస్ట్ ఇది మనకి మీరు అనౌన్స్ చేయడం అది పెట్టి
Check. Check, check.
Yeah.
Back side.
Comprehensive kind of webinar for the last 1 week, and even today all the talks were very exhaustive, so most of the things are already covered. If I can highlight one important thing which I personally like, that is ergonomics. In any surgery, surgeon, if he wants to continue doing with the same peak performance for a longer period of time, they should focus on good ergonomics, so that you don't develop cervical spondylosis, you don't develop spine problem yourself while operating. So always be comfortable while operating anything, whether it is endoscopic surgery or any surgery. You have to be in a comfortable position. So, like specifically for endoscope, I don't like any cables to come in this area. That even if I am holding the scope myself in the initial part of surgery, I always like to hold it like the way madam is holding, so that the cables all will go above, means above the patient, and it is supported. Sometimes the weight of the scope assembly itself will kind of drag your arm, so nicely support it somewhere, so that it should be comfortable, so that even when you are doing a long surgery, you will not get fatigued. So I always tell, if it is my resident also, that they have to be comfortable and they have to see the screen nicely. If my assistant, whether my resident or ENT colleague, if they are not comfortable, then I wouldn't proceed with it. So I'll make sure that they are comfortable standing or sometimes sitting also. So you can do in whichever position, but you have to be in a comfortable manner. And like the way madam is holding, it should be well supported in forearm and in such a way that the fingers, you can do micro adjustment. And this area should be absolutely kind of free, and we keep for, because now most of the OT tables you can adjust later, so even if you keep it in a neutral position also, you can adjust it later. But in the early days, it was recommended whenever you do a transclavial surgery, you are going like this, so you have to flex the neck. But whenever you are doing transplanum or transcribriform, you have to extend the neck. But nowadays you can do that after positioning the patient also. But only thing, if a patient has a short neck and a large chest, then you have to make sure that you don't do flexion. There won't be any space for you to put in your instruments, especially the long instruments. So I don't like flexion. If at all we do mild extension. And another thing, see, there are two ways to visualize a structure and remove the tumor. If you don't see anything, you should not do anything there. So I tell my resident also, when they are holding the scope, as long as you are holding the scope, it is like holding the steering wheel of a moving car. So when you are holding the steering wheel of the car, you don't look at where the accelerator, where the clutch is, isn't it? Your eyes should be on the road. On a moving car, you should always look at the road. You should not look here and there. So I tell my residents that they always have to look at the screen in a comfortable manner, because sometimes lots of disasters happen because they were looking at somewhere else and the scope, either you will break the scope, or when you have exposed carotid and such things, you can go and damage any structure. So you have to be very comfortable, and like these are the basic things. And for you have to have adequate exposure. See, either now we are using 0-degree scope. See, there are kind of two kinds of philosophies. Either you do a bony exposure so good enough that even with a 0-degree scope, you will be able to visualize any structure which you are operating and remove the tumor. Or this rule applies especially whenever the tumor base is close to the skull base, like in case of meningioma or a case of pituitary tumor, where it is close to the base. So you have to have a very good exposure. But in tumors like craniopharyngioma, where the base may be small, but inside it may be large, then you can do the other method using angled endoscope. Sometimes you would have seen that the craniopharyngioma, it is like kind of a spherical structure, and the base may be very small. So you don't need to do a very wide exposure. A small exposure will be sufficient. And another thing is, whenever we are doing for complex tumors, better to do binostril. Whether you are removing the septum or not, but you can always do binostril even without removing the septum, by doing a sphenoidotomy on either side. Whenever the sphenoid sinus is large, you make a sphenoidotomy on one side, you make sphenoidotomy on the other side, use those sphenoid ostium which is enlarged to do a binostril approach. Thereby you will avoid the complications of binostril approach, but without removing septum. So binostril is different from doing a septectomy. But whenever the sphenoid sinus is small, it is better to do posterior septectomy for most of the medium large tumors. For small tumors, uninostril is well enough, is kind of good enough. But for any complex tumor, you have to have a very comfortable exposure by putting both the instruments. See, for example, as I am putting this instrument, this is kind of, I am having some problem here. So that means the middle turbinate is coming in the way. So we don't recommend removing middle turbinate for both sides. For expanded surgery, if at all you want to remove one side, and another side just lateralize it, so that you will have adequate space. Now the middle turbinate in cadaver, you cannot lateralize. So if I do it, it will be crude. But in most of the live patient, you should be able to lateralize the middle turbinate gently. By decongesting, the mucosa will become flattened out, and then if it is a cartilaginous part, you can gently lateralize them. But if it is a concobullosa is if there is a nematization of middle turbinate, then in that case, you split the middle turbinate and do lateral laminectomy, so that you will be able to lateralize them easily. So once you are comfortable in both nostrils, the instruments, sometimes in acromegaly, if the tumor is very large and middle turbinate is totally ossified and very thick, very rarely we do bilateral middle turbinectomy, but I wouldn't recommend it because you have to be careful. And always cutting is better compared to pulling. But for cutting, you either need a debrider or you need a coablator. Both we don't have here. But so whatever kind of manipulation I am doing in cadaver, you should not do it in a patient. We never do it. See, for example, this part, whichever is coming in the way, you should use either coablator or you have to use debrider. So now we are coming from the left nostril. You make sure that the corridor is totally kind of made clear both nostrils. And once you have made it, I already told that for right-handed surgeons, for most of the midline tumors, we the scope is inserted from the right nostril, and when we are inserting in a live patient, the alar cartilage is a flexible structure. So my resident, or most of the time they are used, means ENT surgeons are used to this, but neurosurgeons, we should try to make ourselves kind of very familiar with this. We have to gently retract the alar cartilage in such a way that the nostril becomes wider for the surgeon, so that the instruments can go freely. So using the shaft of the endoscope, you can retract the alar cartilage like this, and this is the place where, like the way madam is inserting, ma'am, you can insert. Yeah, and most of the skull base tumors, we need a parking position of the endoscope. For in this case, now we are parking it in the area of superior turbinate. So we have to clear this area, make a good parking space, so that the endoscope remains in a comfortable manner without coming in contact with soft tissues every now and then. Because that is the most frequent reason why every time we have to take out the scope, then clean it and then put it. So soft tissues have to be cleared nicely. Very rarely, if I don't have any assistant, if my ENT colleague is busy and my resident is also very tired and they don't want to hold the scope, I use endoscopic holder. So it really helps. But I tell my residents that if I keep using endoscopic holder, then they will never get to learn. So I nowadays try to avoid using endoscopic holder unless my resident says, sir, I am tired, you use the holder. And for long surgeries, the recording comes very good because there is no fatigue, or the resident because for any person, but when an assistant is holding the scope, like especially senior people like ENT colleagues, when they are assisting, they unconsciously help the surgeon in a way which is not possible to be done by any holder. So a person holding the scope is far superior to holder. Only I use it as a last resort. But the advantage of holder is that micro adjustments and micro tremors doesn't get transmitted to the recording. So the recording comes beautiful if you use the holder. But when you want to get it out and then insert again and again, it is better to use manual, this thing. So once you have exposed adequately, now for example in this, I think Dr. Subodh sir has already exposed nicely most of the structures, but for sagittal corridor, we need to expose more. If you want to go, that means if you want to go anteriorly here, this is the tuberculum. Can I have a dissector? Can I have a straight dissector? See, for example, if you see this part of the septum keeps coming in the way, that thing has to be cleared off. Yeah, thanks. So anything which comes in the way, it will give a meniscus sign. See, whenever the scope goes close to a tissue, there is a kind of a bright signal comes. That means that structure is reflecting the light because it is very close. So whichever gives that sign, you have to remove from the corridor so that you are comfortable. I have already told that I do it with the coblator. And you should always keep seeing the tip of the instrument. Can I have disc forces? And nowadays endoscopes come with a sheath which can irrigate continuously. So that is also another method. If you have irrigating sheath continuously, you don't have to take out and then this, you can continuously irrigate. Can I have section a little bigger? Can I have a bigger section? Yeah, can I have a section? Yeah, this is quite small. Can I have saline? I think suction is not working. Yes, can I have disposals? So regarding, and whenever we are doing an intradural procedure, we have to take the vascularized flap, and whenever we take the vascularized flap, you'll have to make sure that the sinus mucosa is stripped off fully, otherwise it will cause mucocele formation. And for the flap to be repositioned, the most important thing which causes good healing is the surface area in contact. For that, all these mountains should be flattened out, all the septum should be removed. Wherever, for example, if I want to keep the vascularized flap here, there should not be any septum, there should not be ridges. Wherever there is a dead space, healing will not happen, and mucosal formation will happen, CSF collection can happen, and it will continue to ooze. CSF leak will continue. So, for example, like if any septum is there, that has to be flattened out so that when you reposition the flap, the surface area of contact is the maximum. These are all the posterior ethmoid, and posterior ethmoid have to be removed, have to be opened up, and the mucosa stripped out for all like craniopharyngiomas, tuberculum cellae meningiomas, and olfactory groove meningiomas. So and nowadays most of us have navigation, so navigation will help you to tell how much bony exposure you need. But when we don't have navigation, you have to plan before itself how much of anterior exposure you are going to do. There is only one disadvantage of too much anterior exposure. If you come too much close anteriorly, you are likely to cause anosmia. So remain only whatever posterior to the place where you need. Too much anterior exposure is to be avoided. See, now you can see, can I have the probe? See, you can see, can I have syringe with saline? Can you fill saline and give? See, basically yellow CR corresponds to the nematized optic strut, and MOCR corresponds to 2 points, lateral tubercular crest and the middle clinoid. So whenever we do for a simple macroadenoma, can I have saline? Yeah, some kind of. Can I have the suction little wider? It is getting blocked again and again. No, but that is too short. That is too short. This suction is too short actually. Okay, see, if you can see the lines, can I have a dissector to show the anatomy? Yeah, I think this is the best we are getting. I don't know why. It is not good actually. Focus is not that good actually. And better you do all the bony work before you open the dura, because after you open the dura, if you have to do bony work, it can be very risky, because sometimes you may have to use a drill. So all drilling better do before you expose all the important structures. And sometimes the bone fragments also can get spilled in the intra arachnoidal areas. We usually focus onto the suture material cover, in which the text can be read very clearly. But still I am not satisfied. The focus is still not good actually. Yeah, is it better? Yeah, so you can see one line. Can I have dissector? can I have fine dissect? See, this is the tuberculum. You can see the bluish kind of background here. You can see this corresponds to the tuberculum, and this appears to correspond to the chiasmatic sulcus, and this is the planum. So actually, why we have to know the anatomy is, if you are operating on an infradiaphragmatic tumor, how much ever large it is, if you drill inferior to the tuberculum, you are unlikely to get CSF leak in the initial part. CSF leak in the early part of an infradiaphragmatic tumor surgery is likely to be detrimental, because the CSF will not push the tumor, and the CSF leak, because of that, the turgor of the tumor will get lost. So always be careful here. If you drill, it cannot cause CSF leak. Just anterior to the tuberculum, if you inadvertently injure the dura, it can cause CSF leak early, which is not good. But whenever a tumor is giant, you have to have a very good exposure. You have to remove the planum and and the tuberculum, depending upon. I usually have navigation, so I keep the probe like this and see how much of the tumor I am able to see when the line is extrapolated. So that determines how much bony exposure you want to do. For a craniopharyngioma surgery, we expose half of the sella, and then we expose till the point in which my navigation tells I am able to see. One is for craniopharyngioma, the window through which you can operate is between the chiasm and the stalk or pituitary. Only that window it will be helpful. Even if you do a large exposure like this, but if the chiasm comes here, this part will go waste. So for craniopharyngioma, do a kind of customized exposure. The moment you see the chiasm, you stop, because the further anterior exposure is not needed and it is not recommended, because anterior superior to the chiasm, all perforators are there. If you remain inferior to the chiasm, only the blood supply to the chiasm will be there. So you can visualize. So for cranio, I never expose anterior to the chiasmatic area, and I remove half of the bone over the sella. But for a meningioma, most of the meningiomas have a broad base, and the dural tail also will be there. For them, you have to have a very wide exposure. Sometimes you have to expose till here. Sometimes you have to expose as anteriorly as possible, maybe here, if the dural tail is till here. So that determines how much bony exposure you need to do. So now I'll use drill. I'll drill out the tuberculum. For a pituitary tumor, the safest point to drill is, just 1 minute, the soft tissue comes in the way. Can I have disc forceps? See, any such loose soft tissues which come in the way, better coblate or debride them, so that nothing should keep coming in the way and disturb. But because of lack of time, I am going direct. Can I have drill? So for a microadenoma, we recommend only doing bony exposure over 1/2 of the sella. No need to expose full sella. Can I have drill? And the scope should be far away from the drill so that it doesn't break, and focus should be kept changed, because whenever the distance changes. Is it okay? So if it is a pituitary tumor, let us assume it is a simple macroadenoma. This is the safest area to drill, and just to do it in a rotatory motion, and mostly we do with the diamond drill. I think this is the diamond drill only. But for other parts of the bone, like keel of the vomer and all, we don't use diamond drill, but here we use diamond drill. And most of the time, if the tumor is there, the bone will be soft, so you can just it comes off easily. Without drill also, you can just kind of open, you can do the craniotomy over the sella. I think it's not working. Can I have another section? So for beginners, better to drill the center part and then use upcutting. Once you get experienced, and ball is better than cone, because the cone actually I don't like it. The more it is spherical, and when you are drilling the lateral part, it is better. For example, here the recesses are not that good. There seems to be a bony defect here already. So I think whenever we are drilling, start with center, but when you are drilling the paraclavial area, don't do drill across the carotid. Better to drill parallel to the carotid medially, and then laterally if you want to go, you can drill there. But otherwise, this is a relatively safe maneuver, doing like this. Or if you want to be fully safe and the bone is very thin, better to use upcutting to remove the bone. Once you have made a hole, if you don't want to drill, you remove that bone over there. Try to be in the extradural plane. We use a curved dissector. There are 2 layers of dura here, so it is very difficult to injure the dura, both the layers. So in the center there are 2 layers of dura. Laterally there is only 1 layer of dura. I think today morning it was told in. So the 2 layers, they go away here. So 1 layer, the meningeal layer goes as the medial wall of the cavernous sinus, and so better remain in the extradural area and use upcutting. As long as you are extradural, there is no way. Madam, can you go a little closer? As long as you are extradural, there is theoretically no way we can injure the carotid artery. We can get into interdural sinuses. Here I think anterior intercavernous sinus is bleeding. So most of the venous bleeding will stop. You just pack the area and keep doing. This cadaver is so good that it is showing bleeding also. There is some kind of glaring actually. Can we switch off the light over this? Whenever you are seeing a movie, you don't want to sit in a brightly illuminated hall, so better to make it dark. Can I have some dissector? Most of the anterior intercavernous, it definitely bleeds, so we should keep proceeding by gently packing that area. Sorry. Focus is. There is too much glare, either because of the formalin and also because of the light also. Can we switch off the light? So most of the time the bone is very thin, so even without drill, you can gently do it with the upcutting itself. Anterior intercavernous bleeding, there is only one way it will stop. You should never try to control it by unnecessary kind of small anterior intercavernous sinus. If you can coagulate and do. Otherwise, when you open the dura, the bleeding will stop. Any anterior intercavernous bleeding will stop when you open the dura. So keep proceeding without stopping. And otherwise, you can use a drill. If the bone is very thick, it is better to use a drill. and at some point you can see that there is a change in the orientation of the dura. So that is the area of attachment of the diaphragma sellae corresponding to the tuberculum. The more we keep going, can I have upcutting? So there are some angled upcuttings available, but even without that, till you are able to get the angle, you keep using the upcutting to open up. Start with the central part first, and then start going laterally. Whenever the bone is very thick, drill is superior to doing this. You should never exert force. It should be effortless. As long as it is effortless, it is fine. Then we can go laterally. So now I have exposed a part of the sella, and then I am going over the tuberculum, over the planum area. How much lateral to go? There is no rule, but you should know how much of flap you have taken. You should be able to cover it. I have already told that meningiomas we do a kind of wider exposure, but craniopharyngiomas we stop when we see the stalk in the navigation in MRI. But when you don't know, then for cranio sometime I stop, I open the dura, and then I proceed with more of bony exposure. You can see the diaphragma sellae attachment where there is a, madam, can you take the scope little closer? Can I have a fine dissector? See, you see that there are two layers of dura. Can you appreciate? There are two layers of dura. This is the periosteal layer, and this is the meningeal layer. And here you can see that this is the area where diaphragma sellae is likely to be attached. So if I cut here, I should be able, I should be entering the subarachnoid space. And lateral, how much to go? It depends on what pathology we are dealing with it. But for the sake of doing, can I have a little larger upcutting? You have to do bony exposure from one MOCR till the other MOCR. I think I forgot to tell that. This is the MOCR. See, when you don't find recesses nicely, this is likely to be the carotid bulge. This is likely to be the carotid bulge, and this is likely to be the MOCR. MOCR corresponds to the middle clinoid and the lateral tubercular crest. So from one MOCR till other MOCR, you have to do an exposure. Lateral to MOCR depending upon the tumor or depending upon the pathology. And for a right-handed surgeon, going to the right is easier. Going to the left is difficult. So we use a down-cutting forceps or we use a drill. Because now I am easily able to do it on the right side. But if I have to do it on the left side, it becomes little difficult. So either I can use upcutting, either I can use down-cutting or I can use a drill. But here you have to be careful. When you are going lateral at the area of tuberculum, you have to be careful. This is the area where carotid can get damaged. There is a curve. This is the area of anterior geno. So you have to be extremely careful. The moment you start getting bleeding from the sinus, you can stop and use navigation or Doppler, whatever we have. Can I have upcutting? And let us assume that this case is, we need to do a more of exposure. So let us see. I agree that focus is not that good. Can I have suction? Can I have suction? And knife, I need knife, endoscopic knife. No, this is too short. This suction is too short. It is not reaching actually. So if we For a craniopharyngioma, this much exposure is sufficient. Can I give? Okay, fine. So as Dr. Ramesh is highlighting that bony exposure should be done first, and then only you open the dura. The more anterior we go, the instruments do not have the appropriate angle to safely cut the bone. As you see here, it was easy. Here, it is difficult. You need an angled, angled upcutting. So otherwise, you use a drill.
Hello, mic testing.
Here you are likely to injure the dura, but here anyway you are planning to open the dura. So I won't bother about opening the dura. But when you are operating for a pituitary tumor, you don't want to open the dura. But here anyway you are going to open the dura, so it doesn't matter. As long as it is under controlled and you, in midline, you are unlikely to have any complication. But lateral, you should never hold dura when you are using upcutting. The more anterior you come, it becomes very difficult to remain in the extradural plane. Here there is no landmark to tell which is the chiasmatic sulcus and which is the planum, which is tuberculum. Only the tuberculum you will know. But the chiasmatic sulcus, planum, there is no landmark. So only in the endocranial aspect it is there. In the exocranial aspect, there is no landmark. So mostly we use navigation. And can I have down cutting? See, basically this depression in the MOCR corresponds to the attachment of the keratocondyloid ligament, which is one of the strongest parasellar ligaments. So for functioning tumors, you have to have a very good exposure of the bone over the cavernous sinus. Suction band ho gaya. For microadenomas, small bony exposure is good enough. For a macroadenoma, a medium exposure. For functioning tumors, mostly they enter cavernous sinus, so you have to expose the bone over the cavernous sinus.
Hello, mic testing. Hello.
Okay. Yeah, can I have upcutting? Can I have saline?
Hello, mic check 1, 2, 3. Hello,
Yeah, so
hello,
you
hello,
expose it,
hello.
and whenever we expose, make sure that you remain extradurally. Yeah, see, I was talking about the anterior intercavernous sinus area bleeding. If you open the dura, it will stop. If you want, you can coagulate.
Hello,
but,
check.
But coagulation alone will not work. As long as it is held in a tight manner, it will keep bleeding. The same as scalp bleeding. Scalp bleeding, because of a partial laceration, will keep bleeding.
Mic check,
Full
1, 2, 3.
laceration will stop.
Hello.
So this was the thing which we are taught in
Mic check 1, 2,
surgical
3.
anatomy. So same way, this will keep. If you
Okay,
enter, see, there are two leaves of dura. If it bleeds, if you give an incision fully, it will invariably stop. But cavernous area, when you remain extradural and little bit bleeding which comes, you can pack and do contralateral and then come back here later without any issue. As long as you are remaining extradural, it is unlikely to. Can I have saline? And these bony fragments, sometimes when we are making them thin, you have to be careful that when you are removing them, they don't damage. Suction band. See, for example, these fragments, you have to mobilize them away from carotid. Yes, can I have down cutting? Can I have saline? Can I have a big down cutting? Bigger size? See, basically small instrument is not necessary as long as you are removing a wider area of bone, because small things can make a hole, but bigger instruments are unlikely to make a hole. It is the thickness of the foot plate which matters, not the of the cut you want to do. Okay, can I have upcutting? Can I have saline? Focus बार बार खराब हो रही है. See, this much of exposure would be sufficient. Now my exposure on the right area is better than left. Can we go a little deeper now? This is the area where optic canal is likely to be there. More lateral. Yeah. See, correct. See, we can safely go across the cavernous sinus as long as you are in the extradural area. And you can use a drill also, but just for demonstration, I am trying to do with this. But once you have cut it, then we should not use kind of drill. Either we use drill from the beginning, because kind of drill when the dura is exposed is not safe. Now this side it is exposed, and here if it starts bleeding, just put a cottonoid there, it will stop bleeding. See, this is the area of carotidoclinoid ligament. Can I have dissector where the middle clinoid is attached? See, this is the area where the outer layer is going as the anterior wall of the cavernous sinus. You can see that this is the outer layer of dura and this is the inner layer. So this is the cavernous sinus, and here you are likely to get the middle clinoid. Okay, can I have upcutting? I think I'll open the dura now. It's getting late. Yes, can I have knife? Well, you are likely to get the middle clinoid. Can I have knife? I think I'll open the dura now. If we want, we can coagulate the anterior intercavernous sinus, or we can give an incision. Actually, I give a straight knife, I don't use sickle knife to give incision, but I think it's not there. Can we go a little deeper, ma'am? Because sickle knife cannot give incision, actually. It can only enlarge the existing incision. We don't have knife? Okay, fine. So now I am giving one incision just inferior to the... See, the sharp area is here. It is towards me. And this is the anterior. So you give one incision anterior to the anterior intercavernous sinus, and you see CSF coming, and you do one incision posterior. So now I use a knife. Either we can use a BP handle with 11 knife also. See, the sharp area is here. It is towards me. Yeah. And this is the knife we use. You give one incision anterior to the anterior intercavernous sinus, and you see CSF coming, and you do one incision posterior. So now I use a knife incision So I gave two incisions, one anterior and one posterior.
The sharp area is here, is towards me.
Or if it is a supradiaphragmatic tumor, only one incision will be sufficient, and then you can cut the diaphragma sellae in the midline little bit. And then we use through cutting forceps to cut the remaining part of the dura. Can we have forward angle through cutting forceps? Or if it is a supradiaphragmatic forward angle through cutting, only one incision, forward angle vahanta, and then you can cut the diaphragma sellae. There was an upward angle through cutting forceps, and then we use through cutting forceps to cut the remaining part of the forward angle through cutting. Can we have forward angle through cutting forceps? So anyway, or if it is a supradiaphragmatic forward angle through cutting. Yes, forward angle vahanta. And then you can cut the diaphragma sellae. There was an upward angle through. I usually cut it and then we use across. See, once you have cut anterior and inferior, superior and inferior to the anterior intercavernous sinus, then when you cut in the midline, when it retracts, it stops bleeding, even without coagulation. If you want, you can coagulate, and most of the dura, see, either you can reflect it and then close it back, but in meningiomas you have to kind of have a big opening. So we use through cutting forceps. Through cutting forceps was there just some time back. In the morning it was there. Forward angle through cutting. See, this is a very good instrument for cutting the dura. If you want, you can coagulate, and most of the dura, see, either you can reflect it and then close it back. But just holding. But in meningiomas, you have to kind of have a big instruments are always better. So we use through cutting forceps. Through cutting forceps was there just some time back. In the morning it was there. Forward angle. See the chiasm. See the chiasmatic sulcus. What we see in bone, it is not necessarily the same what you see intradurally. So it can be a prefixed chiasm or post-fixed chiasm. Can I have some other cutting thing for dura? Forward or straight, whatever, through cutting forceps. This is not cutting actually. There was a big through cutting forceps I saw in the morning. It is not necessarily the same what you see intradurally. So I am holding it, it is not cutting. These are the most dangerous instruments. Can I have some other cutting? And this flap of the dura, if it is, forward or straight, whatever, through cutting forces, this flap of the dura will impede our view. See, this much of bony exposure will become waste, but this is little big mouth. This is not necessarily the same what you see. We have to use little finer ones. I am holding it, it is not cutting. This is suction. This is not. Can I have some other cutting? Can I have suction? And this flap of the dura, other suction? Forward or straight, whatever, through cutting force. This flap of the dura will impede our view. See, this much of bony exposure will become it's not working. Can someone clean the suction and give? Can you please clean this section and give? I am holding B is not cutting. Suction. Yeah. It's not. Can I have some other cutting? Can I have suction? Ma'am, you can focus. Other section. Yeah, they will do it. This flap of the dura see, as long as this dura is there, you cannot see the lateral structure. Can someone clean the section and give? I should not do this, but anyway, we are not supposed to hold the dura with this instrument, but even this is not cutting. I need some instrument to cut this. See, as long as this dura is there, you cannot see the lateral structure. कोई भी cutting forces नहीं है आपके पास. We are not supposed to hold the dura. This is not recommended for dura. Even this is not cutting. I need some instrument to cut this. Yes. See, as long as this dura is there, you cannot see the lateral structure. These are grasping forceps actually. कोई भी cutting forceps. Can I have cutting forceps? Something. You are not supposed to hold the dura. No, it is not cutting at all. The forward angle through cutting is the best instrument. This is the one, but it has become blunt. As long as this dura is there, you cannot see the lateral structure. These are grasping forceps actually. The more we use force, we can go wrong. So actually complications happen when the cutting instruments don't cut and they hold. But anyway, now let us go inside. So we can see the chiasm and stalk. So actually this is the window I was talking about. how much ever large a craniopharyngioma is, you have, madam, let someone else put section.
The more we use force, we can go wrong. So actually
So
complications
how much ever
happen
large
when the cutting
craniopharyngioma
instruments
is,
don't cut and
the
they
window
hold.
you have is only this. Can I have
But
dissector?
anyway, now let us go inside. So we can see the chiasm and stalk.
So this
So
is the
actually
only
this is the
window we
I was
have.
talking about.
The moment,
How much ever
see,
large
this
a
is the diaphragma
craniopharyngioma
sellae,
is,
this is the stalk.
you have, madam, let someone else put section.
If you see the stalk, you can guess where the chiasm will be there, and when you see the chiasm, you can guess where the stalk is. This is almost the stalk is always attached at the posterior aspect of the chiasm. So the moment we go superior to this, you are likely to get complications. Here you will get ACOM and perforators, everything. So this corridor is not recommended for craniopharyngiomas. For meningiomas, mostly this chiasm will be pushed superiorly. For cranio, you better go on one side of the stalk if it is pushed on one side, like this. Can we go little deeper?
Perforators, everything. So
If you see the stalk, this is the superior hypophyseal artery which comes. The advantage of endonasal endoscopic is the perforators on the undersurface of the chiasm are best visible here. So any tumor which is stuck here, if it is a meningioma, see why this is better is in meningiomas or craniopharyngiomas, if it is pushing the chiasm from below, the undersurface cannot be visualized by transcranial approach compared to endonasal. If a tumor is superior to this, transcranial is better. If a tumor is behind this also, endonasal is better, because you see the hypothalamus, now I'll be showing. But here this kind of like the bilateral optic nerve visualization is best with endonasal approach
compared to endonasal.
So this is the problem, we are not getting an instrument to cut this. We are seeing it, we are not cutting.
If a tumor is behind this also,
Yeah, it is not
endonasal
working
better
actually.
because you see the hypothalamus now.
So if you want to mobilize this, for example, the stalk is in the center and you want to go lateral to it, this kind of upcutting you should not use, but even this one is not cutting.
If a tumor is superior to this, transcranial is better. If a tumor is
Yeah,
behind
that's a
this
good
also,
idea.
endonasal is better.
But I am actually causing avulsion actually.
So if you want to mobilize this, for example, the stalk
Yeah,
is in the
that's a-
center and you want to go lateral to it.
As long as they don't quote the Neuroendoscopic Society is officially recommending this, it's fine. So now you can see, if you want to mobilize by going lateral, can I have saline? Yeah, that's a good idea. But I am actually causing avulsion actually. Okay, can I have dissector? Can I have some nozzle, some syringe in which? As long as they don't quote the Neuroendoscopic Society is officially recommending this. See here actually,
So now you can see,
till now we are using with 0
if
degree.
you want to mobilize by going lateral, can I have saline?
Yeah.
But I am actually causing avulsion.
Just for exposing. So the moment I see chiasm, I stop, because even if I do a larger exposure, it is not useful. And if I want to mobilize this pituitary with the stalk, the only way to do is by doing a transposition. I have already told that there are 2 layers of dura here. Just for exposing. Here the keratocondyloid ligaments are attached to the medial
Even if I
wall.
do a larger exposure, it is not useful.
You can cut here and then
if
mobilize
I
this
want to
portion.
mobilize this pituitary with the stalk. The
So
only
that-
way to do is by doing a transposition. I have already told that
Can
there
you
are
go
2
inside
layers of dura here.
If you want, see, here you are seeing some bony prominence, that is the posterior clinoid or dorsum sellae attachment. So here there is some attachment, isn't it? Parasellar ligaments. So you can cut it. Can we have scissor?
To do is by doing a transposition.
Yeah, any scissor.
Told that there are 2 layers of dura here.
If you want, so you can cut that.
Here you are seeing some bony prominence. That is the posterior clinoid or dorsum sellae attachment. So
No, superior hypophyseal we have to preserve as far as possible, because this is the superior hypophyseal.
Can we have scissor?
But now because here we are using crude instruments,
it has got avulsed, but you should try to preserve as much as possible. And then you can gently mobilize this. And most of the time in cranio, this corridor would be already expanded. So what you are seeing is the lilicus membrane. The lilicus membrane, when you open only, you will see the it has got avulsed, but posterior circulation. So can I have some fine dissector? And then you can gently mobilize this. And most of the time in cranio, this you can see that this is the carotid expanded. So what you are seeing is the lilicus. You can see the branches of the carotid. Membrane. When you open only, you will see this is the pecom, which is making a hole in the dorsum. Sorry, in the lilicus membrane. Fine dissector. Then you can gently mobilize this. So this is the mammillary body, and this is the PCA. You can see so this is the PCA, and where the pecom is getting attached to the PCA. So this is the mammillary body. So craniopharyngiomas beyond the mammillary body, you should not be aggressive in children, and you can gently mobilize and remove the tumor. And most of the craniopharyngiomas are in this plane. They are around the stalk. Can we have saline? And where the pecom is getting attached to, can someone else irrigate actually? So this is the mammillary body. So craniopharyngiomas, see, most of the craniopharyngiomas arise from this area around the stalk. So either they are transinfundibular or they are pre-infundibular, then the tumor will be here. It will be, that will be the easiest thing. It will be pushing the chiasm above. So you can go and dissect it and nicely remove it by preserving the stalk. Infundibular tumors are the most difficult, and in transinfundibular you cannot remove the tumor without excising the stalk. So if it is a third ventricular craniopharyngioma, it is arising from here and it will be in the third ventricle. So now this will be the area where it will be getting into the third ventricle. So because this ventricle is small, we will not see it nicely, but in a third ventricular craniopharyngioma, this area would be exposed. It will be enlarged automatically. But in a transinfundibular, you will have to, if you want to excise totally, you will have to cut the stalk. So in transinfundibular, they go along the infundibulum and they go into the third ventricle. So they will be there either infradiaphragmatic or in the cisternal area, or it will be in the third ventricle. But in a retroinfundibular cranio, you can go on either side and by preserving the stalk, or you can decide to cut the stalk. But when you are electively cutting the stalk, it is better to cut it inferiorly. But here I was trying to show it in entry into the third ventricle, so I was cutting it here. But whenever you are electively cutting, but in a retroinfundibular cranio, you can proceed. So just 1 minute. I'll just show the ACOM. Decide to cut the stalk. So this corridor is better not used because I've told you lots of perforators are there. As you can see, this is the ACOM complex. So here, even if tumor is there, and dissecting the tumor from the perforators is extremely difficult. So better you use the infrachiasmatic corridor only for removing. And this corridor is can go little inferior, little deeper. Lots of perforators are there. So if you go little down, you will be seeing the complex. So here, if you use angled scope, you will be able to. This is the third nerve. So this is the third nerve, and below that you are seeing superior cerebellar artery. So the same way on either side, they are always in relationship with mammillary body. So this is the basilar top, third nerve, and pecom and ICA here. Can we come little out, man? So this is the ICA. This is the third nerve. This ICA, and this pecom is going and attaching to the PCA. So the same way I think you can proceed with hands-on now. Relationship with mammillary body. So this is the basilar top, third nerve, and pecom and ICA here. Thank you, madam. So this is the ICA. Good that it didn't heal. This ICA, and this pecom is going and attaching to the capillary artery. So the same way I think you can proceed with hands-on now. Relationship with mammillary body. So this is the basilar top, third nerve. No, I didn't know the time. I was asking. Thank you, madam. So you the IPA, good that it didn't. BCom is going and attaching to that, you are seeing a video principal. So you can proceed as I didn't know the time. I was asking. I didn't know the time. I was asking.
videos and I did not include in the PowerPoint because they were so I kept them separately. It's better I get patients who want to get it.
Maybe.
Videos, videos only. Escape. Just separate. No, and switch up.
Present yes, ma'am. Slide.
Thank you very much for and this is the easier case in the middle of the campus science. And we had about 25% of the legal science. There is enough media, something we do rarely, but humor. There is enough curve to be mindful of.
Everyone, hello. Hello. Everyone, if completed, please carry. We'll go to the auditorium for how I do session. Please forward. Hello. Hello. Everyone, if completed, please carry. We'll go to the auditorium for how I do session. Please forward. Hello. Hello. Everyone, if completed, please carry. We'll go to the auditorium for how I do session. Please forward. Everyone, if completed, please carry. We'll go to the auditorium for how I do session.
Thank you very much for inviting me to the particular change. The meta-analysis showed the remission adenomas is about 50 to 60% and is below 50%.
Hello. Table B, C, D, E, please proceed to auditorium. Hello. And whenever you are attending a cadaver workshop, for every
Table
delegate,
B, C, D, E,
as a
please
respect to the
proceed to
cadaver, please
auditorium.
keep the area clean after you finish your
And
dissection.
whenever you are attending a
That much
cadaver
respect
workshop
can be
for
shown
every
to the
delegate,
cadaver.
as a respect to the
Don't
cadaver,
throw
please keep
everything
the
here
area
and
clean
there.
up.
Arrange your instruments, clean the all the
much
tissue,
respect
put
can
it
be
in the
shown to the
dustbin and
cadaver.
then leave.
As a respect to the
Don't,
cadaver,
that's the
throw
basic
everything
of
here
any
and
cadaver
there.
dissection course you attend.
Arrange your instruments, clean the all the tissue, put it in the dustbin and then leave. That's the basic of any cadaver dissection course you attend. Arrange your instruments, clean the all the tissue, put it in the dustbin and then leave. That's the basic of any cadaver dissection course you attend. minutes లో స్టార్ట్ చేస్తాం ప్లీజ్ వీఆర్ స్టార్టింగ్ ఇన్ 2 minutes జస్ట్ ఇన్ఫార్మ్ అవుట్ సైడ్ ఇన్ ద హాల్ Dr. Suchanda. Dr. Suchanda, Head of Department, Nizam Institute of Medical Sciences, requested to join here for chairing the session. Dr. Suchanda, Head of Department, Nizam Institute of Medical Sciences, requested to So this is running 10 minutes late. So that's Ramesh didn't do this. So we start with the how I do it session here. So we have some interesting talks. The first talk is by Dr. Dipankar Singh. Dr. Dipankar Singh. We start with the how I. Dipankar Singh. And he's going to talk on endoscopic pituitary surgery, diverse cases. The time allotted for talk is 5 minutes. We'll have the discussions at the end. So Dipankar is from VMC and Safdarjung Hospital, New Delhi. Yeah, Dipankar, please.
Good afternoon, everyone. Respected chairperson, colleagues, friends, juniors. So I shall be presenting some of the diverse cases for endoscopic pituitary surgery. So what is our technique? We use a binostril approach. It's a completely endoscopic approach. I use a four-handed approach for almost all the cases. We use head-art flap for large and giant tumors. Hemostasis is of utmost importance in these cases. It's always teamwork. Experience definitely matters, and a multi-layer closure should be done. So this is the technique. Sometimes we use holders. Sometimes the endoscope is held by the assistants. I sometimes use this surgical powder for closure. This is the setup, how the pituitary surgeries are done by our team. The assistant holds the endoscope. The surgeon is in the center. The scrub nurse is along with the surgeon. Everything depends upon the ergonomics. So showing some of the cases, some of the diverse cases and the technique. So this is a pituitary case, a giant pituitary adenoma. The technique is like as described by the textbooks. I always use a binostril approach. The head-art flap is fashioned. The drilling is performed completely. The technique is like you can see the drill being used to drill out the vomer completely. The sella is exposed and tumor is excised. So this is just showing. and then reconstruction. Another case showing the similar technique. You can see there was a small leak at the end of the procedure. A gross total excision was performed. Multi-layered closure was done. Another case, another unique case here, Sellar-based pituitary tumor. Cavity being shown here at the end of the exposure, a beautiful cavity with the excision of the tumor. Another unique case having multiple septations here, drilling done to remove and make it as a single cavity at the end of the beautiful
Come
exposure.
to your conclusion slide.
Some crushing cases, some more unique cases, geriatric cases, acromegaly cases. So take home message is endoscopy is a unique approach for pituitary tumors. It has a definite learning curve, and management of complications if they happen is of paramount importance to have a good outcome for the cases. Thank you.
Thank you, Dr. Dipankar. Next, we have Dr. Rakshit from MS Ramayana.
Another unique case here, Sellar-based pituitary tumor.
Good afternoon, respected chairpersons, ladies and gentlemen. At the outset, I would like to thank Dr. Ramesh for having given me this opportunity. Since morning, we have been learning about the endonasal anatomy and the surgeries that we can perform through the nose. Extended endonasal approaches were made possible by the development and understanding the vascularized nasoseptal flaps. Of extended endoscopic skull base repair is to divide or separate the cranial cavity from the sinonasal cavity using a multi-layered technique. The skull base repairs have evolved over time, and in 2006, Haddad et al. Developed the well-known Haddad flap, which is the workhorse for skull base repairs. They published their work in 2006. The benefits of this flap is reliable blood flow, reduced CSF leak postoperatively, and a large vascularized pedicle flap, which was very versatile and was able to cover from the frontal sinus all the way posterior to the dorsum saline clivus. I would like to describe the video article which we published in Neurology India in 2021, a modification of the Haddad flap, which is a bilateral posterior nasoseptal layered technique. The skull base repairs Something have else is evolved playing. over time. It's and in in no- 2006, Haddad et al. Developed Whatever the I spoke well-known before. Haddad flap, which is the workhorse for skull base repairs. They published their work in 2006. The No, no, benefits of this this is not flap the is audio. reliable blood flow, reduced CSF leak postoperatively, and a large vascularized pedicle flap, which Yeah, this is double-breasted over the right nasoseptal flap to cover the complete defect. So we have performed nearly 170 cases in which we have used this double breasting technique. We have had about 4% CSF leak and anosmia in about 10% of the cases, which improved within 2 to 3 months post-operatively. Thank you.
Thank you, Rakshit. All the speakers will have the questions at the end of it. The Bansal is not there. Next, we have Dr. Janvi. No, sorry. Dr. Thirumal. Sorry. Dr. Thirumal is going to speak on tricks and trade in visual outcome improvement in anterior skull-base meningioma via extended endonasal endoscopic procedure.
Respected chairpersons and my dear colleagues, first of all, I thank the Ramesh and team for having me over here, and I congratulate for the successful conduction of the conference. So, in our hospital, I would like to share our experience of tuberculosis meningiomas and the lessons learned and the visual outcome in that. The brief anatomy of the anterior skull base. As you know, the anterior skull base starting from the tubercle. Whether this endoscopic endonasal is complementary or it both fight to each other. But I recommend that they are both complementary to each other, and especially in tuberculosis meningiomas and Planum meningiomas, the visual output is better improved in endoscopic endonasal approaches than transcranial approaches. So what is the rationale for endoscopic endonasal approaches via in tuberculosis and Planum meningiomas? If you observe blood supply, most of the blood supply to the chiasm coming from the ACOM and superior hypophyseal artery, and this is the corridor which we go through the this is the corridor through which we go through the transcranial approach, where the tumor is lying here and pushing the chiasm up and already straining these tiny perforators, and this approach through this inter-opticocarotid corridor and inter-optic corridor might endanger these valuable perforators, which will be saved by the preservation of arachnoid through the endoscopic endonasal approach. So other main advantages, you all know the natural trajectory and early devascularization and effective removal of a hyperostotic bond, achieving a good Simpson strain grade and no retraction of the vein. And medial optic canal decompression can be safely achieved via endonasal endoscopic approach than transcranial approach, where if there is an invasion of the tumor into the optic canal. And you know, we can achieve high gastrostomal resection pain and preserved arachnoid pain is a very important thing, and less risk of iatrogenic injury. This the studies, if you observe the studies which underwent transcranial approaches, the visual preservation rate and improvement rate is much higher when compared to the transcranial rate in endonasal endoscopic approaches. This is our study showing 13 patients have almost a good preservation rate, and 76.9 patients have improved out of 100. So what are the ideal cases? Midline tumors are tumors less than 4 centimeters in size with no lateral extension and entrap vessels. And these are the where if there is an entrap vessels, this is the additions rather than wrapping is taken into consideration. And this is the paper by Dr. Planum et al. Where they have demonstrated that it can be excisable despite having encased ICAs. Medial optic canal decompression can. And to conclude, anterior cranial fossa meningiomas are safe to deliver with better visual outcome in traditional approaches, and careful selection of the cases and shallow just anatomy is very important.
Thank you, Dr. Thirumal. Next, we'll have all the questions at the end. We have Dr. Janvi Jayesh Bhate from Kochi.
Preservation rate and improvement rate is much higher when compared to the transcranial rate in traditional approaches. This is our study showing 13 patients have almost a good preservation rate, and 76.9 patients have improved. What are the ideal cases? Midline tumors and tumors less than 4 centimeters in size with no lateral extension and entrap. And these are the where if there is an entrap vessels, this is the additions rather than wrapping is taken into consideration. And in the paper by Dr. Planum et al. Where it's demonstrated that it can be excisable despite having.
A very good evening to everyone. First of all, many congratulations to the organizing team and Dr. Ramesh for this wonderful academic session, and thank you to the organizers for this opportunity. The topic given to me today is intraoperative and postoperative management of CSF leak in endoscopic endonasal skull-base surgery.
Thank you, Dr. Thirumal.
The etiology of CSF leaks is divided into traumatic, spontaneous, meningoencephalocele, and iatrogenic. Today, we will speak about the repair of iatrogenic leaks during transnasal surgery. Let's do a case-based discussion at the moment. This is the case of a 55-year-old lady who came with severe headache, and MRI showed a sellar and suprasellar lesion, mild suprasellar. Duct in the nasopharynx.